Dr. Michael Bishop. I'm a board-certified anesthesiologist working at the University of California, San Diego. I'm the co-chair of this committee with my fellow board member and mentor, Barbara Yaroslavsky. I want to reiterate the mission of this task force, which is to identify ways to proactively approach and find solutions to the epidemic of prescription drug overdoses in this state through education, prevention, best practices, communication, and outreach by engaging all stakeholders in this endeavor, with a vision to significantly reduce prescription drug overdoses. Thank you all for making time to be with us today. At this point, I'd like to introduce my colleague, medical board member, Barbara Yaroslavsky.
Thank you, Dr. Bishop. Good morning, everyone. I am Barbara Yaroslavsky, and I'm a member of the Medical Board of California. I'm a public member. Today, we want to focus on identifying best practices or methods being used to eliminate the abuse and misuse of opioids in the community. For the public, it may be more outreach. For physicians, it may be increased use to the board's new guidelines, in addition to other educational opportunities. Ultimately, it would be nice to put educational materials into a pamphlet for different audiences. We could develop one for the public and one for our licensees. Based upon our mission for this task force, we want to identify best practices for prescribing by first revisiting our guidelines, which we have done that. We did release new guidelines in November of 2014, and you should make yourself aware of them. They're on our website. However, we also want to educate prescribers on best practices for prescribing, such as ways of identifying individuals who may be drug-seeking individuals, or ways to dispose of drugs, or developing information on ways to protect your medication, and any other ideas you, the stakeholders, may have. Any information gathered could be provided to the appropriate audience, be it the prescriber or the patient.
Great. So today we want to ask our stakeholders to present their ideas and methods that they have identified which may assist us all in our endeavor to eliminate opioid misuse and abuse. Part of the process for finding best practices is hearing from individuals who are patients, those who are treating patients, and those who are supporting those treating patients. It is also useful to hear from those who are creating and implementing policy. Today's discussion provides an open forum to hear from these individuals and learn from their experience. Please be aware that the disclaimer for today is that any individual speaking today has not been endorsed by the medical board. It also does not mean the medical board has approved any method or format identified today by virtue of a presentation here today. In addition, we hope that all speakers present methods that they have found useful and that can be used by all. In order to prepare for agenda item 6, which is public comment, I would like to invite you to sign up on the back table if you wish to speak. For those on the phone, please press *1 to be put in the queue for the later presentation. We may need to limit the time depending on how many individuals want to speak.
Lastly, we want to also be cognizant of the fact that there are patients who appropriately need prescribed opioids. We do not want history to repeat itself, as we learned in our very first meeting of this task force. We do not want the pendulum to swing back to where it was in the early 90s. As discussed in our new guidelines, which was actually started at one of those task force meetings, medicine is practiced one patient at a time, and each patient has a different set of circumstances. We are very fortunate today to hear from Jason Smith. Mr. Smith has attended several other meetings to discuss his experience with opioids and how they impacted his life. We thought that prior to hearing about best practices, we would hear from Mr. Smith to help us understand why we are here and why this issue is so important. In addition, we thought Mr. Smith may also have some recommendations based upon his personal experience about how to improve our system. Mr. Smith, would you like to have a microphone, or where are we going to have?
I think I'm.
You just need to turn
You're
it on.
you're mic'd.
I believe so.
You're wired.
Well,
You're
mic,
on.
I don't know if it's. There we go.
Is that good?
It's green.
Green is good.
Oh, they say so.
Trying to figure out where to stand here.
Here, you can stand right in front of me. No, I'm going to look over there.
Oh, okay.
I can hear with my ears. And you don't need to see me.
Is that how that works?
Yeah, I try.
My name is Jason Smith, and thank you guys to the board for having me. You can see from the title that this is a generation lost, and first off, I want to commend the state of California has done some really good things in terms of making prescription drugs more difficult to come across. It's far less prevalent than it was 10 years ago, and I'm saying that as someone who abused the system 10 years ago. Congratulations on that, because that's really good for the next generation. That's going to be really good for the kids who are in high school now, or the people who come up and they get an injury now. That's going to be really good for them. And that's great, because down the line, I think that's going to be very positive. Unfortunately, we are still left with what to do with this generation who came up in the late 90s and the early 2000s, mid 2000s, who came up during that time. What do we do with them is the question. Because we have this preconceived notion of what a junkie looks like or what a drug addict looks like. And the first thing we're going to have to learn to do collectively is we're going to have to learn to sort of disregard that. Sure. The first thing we're going to have to do is sort of collectively disregard how we envision or what we see a drug addict to look like, because it's not always going to look like this. And if we've learned anything from the prescription drug epidemic, we've learned that this isn't what the modern drug addict looks like. Sometimes we'll see somebody like this, and it's easy. I don't know about you. When I see somebody like this, I always wonder sometimes, how did that happen? Like, at what point in this person's life did they decide that it would be easier to live on the street, or that was their only option? And I'm here to tell you that sometimes this is not what the drug addict looks like. And I can speak for me.
Sorry.
Nobody's taking drugs today, right?
We're learning.
Yeah. Perfect.
That's perfect.
This is not always what a drug addict looks like. I can say for me personally, this is when I got hooked. And this is when I was 17 years old, and and this is just my own personal story, and I wish it was a unique story. I wish my story had value that by itself was just, it was an outlier. And I can tell you, as somebody who's been in this system, I'm not. I was 17 years old here, and I got in a car accident. And after the car accident, I'm not sure what happened, but somehow the medications that were approved and passed for this guy got prescribed for this guy. And when I say that, I was put on medication. I was put on fentanyl patch, and I was put on Norco and Soma. Those were the three. And the fentanyl they gave me after an operation for acute pain. And that was the point that really the addiction started for me. And again, 17 years old, never touched a drug, never interested me. But when this hit my system, don't get me wrong, I loved it. And it's sort of, I feel like I'm in a unique position because I ended up going the next 16 years abusing these medications. And for my own personal recovery, I have to take personal responsibility. I'm personally responsible. So for example, I was never really honest with my doctor because I was afraid my doctor was going to cut me off. So I told my doctor, and I knew very well what my doctor wanted to hear. And I told him what he wanted to hear, and he gave me what I came to get, and it was really a quid pro quo, mutually beneficial relationship for everybody. And I did that. So I'm responsible for that. I'm the one who was not honest with my doctor. Having said that, I have to also, as a writer, because that's what I do for a living, is step outside of my own personal experience and look at the system as a whole and say, where were the breakdowns, where were the flaws? And what I don't want to do in this presentation is get into the blame game. Because it's so easy to say, well, who's the pharmaceutical reps? No, the pharmacy companies. No, the doctors. No, I don't want to even get into that game because as long as we're fighting with each other over who's to blame, we're not even approaching the solution. And so this was my thing. And then, as I said, the Norco and the Soma, I didn't know at the time, and I'm pretty sure my doctor didn't know at the time that when you combine the Norco and the Soma, you get a heroin high. Again, my doctor didn't know any better. Yeah, my doctor wasn't sinister. My doctor was trying to keep me out of pain. And this is what I fell into. I became thankfully not one of these statistics, but this is a statistics of death for prescription opioid relievers over the years. And you can see this is just the people that died. And I'm very fortunate that I'm not one of these statistics. Very fortunate that I'm not one of these statistics. But this is, you can see the trajectory of at some point, it just became not okay to be in pain. Society, it's a sort of a societal perspective on how we view discomfort. My son, yesterday, I was playing with my son, and he had a box from like an e-cigarette. I smoke e-cigarettes, so go ahead and don't judge me. If that's the one thing you judge me on from this leaving, then you weren't paying attention. He was hitting himself in the head with the e-cigarette, and he said, "Ow, hurts." He's facing me, turning away from the TV, facing me. I said, yeah, don't do it. He did it again. Ow, it hurts. Don't do it. So he continued to do this while I'm the only one seemingly who cared about whether or not Curious George made out. My son is just looking at me, hitting himself in the head, saying, this hurts. Eventually, he stopped doing it. He stopped doing it, and it made me think, because I knew I was presenting this morning, if we blow that up and we fast forward to, let's say, my son is somebody in his mid-30s in the year 2003, and he goes to his doctor, ow, this hurts. That doctor more than likely would have treated the hurt instead of saying, well, don't do that.
Exactly right.
Don't do that. Oh, it hurts when you stand like that? Then don't stand like that. At some point, it became, no, we're going to numb what hurts, and we're going to take away your body's natural response to saying, don't do that because this is bad for your body. We're going to take that out. We're going to numb it. Now, that's not to say there are not, like you said in the beginning, there are not people who really need these medications. Okay, but at some point, that generation, the one who went to the doctor with a small pain and got put on Norco or got put on Oxycontin or got put on Percocet, this is who we're talking about with this generation. This is like, you see these numbers, and this is like, it's like one of those scenes in Braveheart where you just got a massive amount of people. These are just the ones that got hit with arrows. There's a whole rest of them, and we collectively have to decide what are we going to do because the numbers are vast. We've taken away the prescription drugs. We're trying to take those off the street, which is great, like I said. But unfortunately, there has been an unintended consequence in this, and that's been the doubling of heroin use. And people who are addicted to the prescription drugs, this was a New England Journal of Medicine study from 2012. 76% of current heroin addicts started by abusing prescription drugs, so more than 3%. And of those 76%, 90 switched because the medications became harder to find or too expensive. So we see this increase in heroin. So we're doing a great job, as I said, as a state, we're attacking the supply. But here we have an increase in heroin. We have the supply and we have the demand. If we just look at drugs as a commodity, which I think is fair to do, we can look at the supply and we can look at the demand. And as the supply, we're doing, like I said, as a state, I think we're doing a great job with the Cures program, with the prescribing practices. The doctors and pharmacists are much more aware today than they were in the year 2000 of what's going on. And I don't think there's anybody who can deny that. Law enforcement is more hip to the game. The number of DUIs, for example, you see from prescription drugs has shot up because officers are more aware of what to look for. ER and urgent care guidelines. All of these things are really positive and is doing a great job of keeping the drugs off the street. But again, that's for the next generation. What are we doing for the current generation? That's my question to you. What are we doing to touch this demand? Because if we only attack the supply and we don't touch the demand, all we're going to do is drive the prices up and we're going to make it harder to find. We're going to drive the prices up and we're going to make it harder to find. And if you see, that's the precise reason people have switched over to heroin. So if we look at the demand, this is just my idea. I'm not a doctor. I'm not, you guys are much smarter than I am. But if we look at the demand, if we look at an idea in terms of everybody working together to attack the demand, at the same time we're attacking the supply. If we have doctors and have a relationship where the patient understands that the doctor's not going to cut them off just for being honest. That's the biggest fear. I can tell you right now, I used for 16 years, my biggest fear was being found out because I'd be cut off. So I never told my doctor the truth. But imagine a relationship in which a patient can come to a doctor and say, hey, I'm struggling with this. And the doctor isn't going to freak out and just say, oh, you're not my problem anymore. You signed a pain contract. You're out of here, which is what has happened. And the doctor can say, look, let's get you some help. And then the doctor transitions them to a detox and a stabilization. And there they have a medically supervised detox off of the medication. And then from there they transfer them to an intensive outpatient or into some sort of inpatient program to get them the help they need, and then back to the doctor, where everybody in the system, everybody along every step of the way is working together. Because right now it seems, from what I hear, and I go to a lot of like 12-step meetings, so you hear stories. Like I hear stories that, of what different people have been through. And what's happening right now is nobody wants to touch the demand. Nobody wants to touch the problem. I don't know if it's a liability issue. I don't know if it's a cost issue. I don't know what it is, but doctors don't want to touch. If you're the patients, if it comes out that the patient's abusing the medication, the doctor just wants to discard them. Go, you be somebody else's problem. And we're having a hard time getting the people into the system. But if we attack the supply and we attack the demand at the same time, but I urge you, if we are only attacking the supply, we are going to cause a much greater problem than we started with. Because at least if they're abusing medications in the medical system, at least if they're abusing in their doctor shopping, at least in that sense, they're still accessible. We can still reach them. Once they go over into street drugs and they start doing heroin, that heroin dealer is not going to say, hey, you need help. A doctor can still do that. So I urge you, if we're only attacking the supply and not the demand, we're going to create a bigger problem. So, that's my story. And like I said, the state of California, I feel like, is doing some really positive things for the next generation. But we have this whole generation of people who grew up in the 2000s and the late 90s. What are we going to do with them to treat them? And I know it's expensive. And I'll end with this. I know it's expensive. And somehow, it's a little bit baffling to me how the pharmaceutical industry has sort of gotten off scot-free from paying for some of this treatment. I mean, they've admitted to lying about the dangers of the drugs when they sold them to doctors. And in every other industry where addiction is a byproduct, whether it be alcohol, whether it be tobacco, whether it be gambling, who helps fund treatment for addiction to those? The actual industries themselves. And somehow we have an industry, the pharmaceutical industry, where a byproduct is addiction. And somehow they've gotten off from paying for any of this treatment. And we're starting to see lawsuits. We're starting to see Santa Clara, Orange County, Santa Rosa County, where the counties are starting to come together and they're trying to sue these companies to recoup some of the costs. But I know this is not going to be cheap, and I know along the way this is going to cost money. And my only suggestion is there's money out there. People are making money off of this epidemic. People are profiting off of the drug epidemic. So there's money out there for treatment. It's just how we're going to access it. That's it. Thank you.
Don't go anywhere.
I believe we're going to have about 5 minutes of public comment, and if anyone has questions. But I wanted to take one of the chair's prerogatives here and mention that you may or may not know that with this cures that's coming out, when the payment for this went into committee, the payment for this multi-million-dollar project, it had earmarked funding from both Big Pharma and Big Pharmacy. When it came out of committee, it had none of that. So I would encourage you, I'm sure I'll get a call from the governor's office today, but I would encourage you, all of you, to speak to your local representatives about this. Why is it that we are not holding responsible those individuals who have profited greatly from this and helped to create this problem? I think that a grassroots effort is in order from my perspective. So I'll leave that to the audience now. If anyone has any questions, please let us know.
Do we have any questions from anyone? Mr. Smith, I want to thank you, Mr. Smith, for your comments as well, though it's not my turn to speak, I'm sure. But I want to suggest to you that you hit the nail on the head with the need for everyone to participate to make a difference here. And I would suggest that even that happy face that on the chart that we've all seen in doctor's office, how much pain do you have today, 1 through 10? It's very easy to just point to the number and tell the doctor what your pain is versus have a conversation with the doctor. So if we could get rid of that to start with, at least we could ensure that there would be more of a conversation. So you want a public comment?
Yes, I would like.
Question
Yes,
for Mr. Smith?
Well,
Microphone?
for him, but also regarding your comment there with the, just give me 1 second.
Well, we'll get a
We'll
microphone.
get you a
so everyone can
microphone.
hear you.
So
We
the
want
issue is,
everyone to hear this.
I was taking chair's prerogative as well. No, but no. So I was doing along with.
No, by all means.
So, but if your question should go to,
Okay.
you can,
Please
you'll have
identify
public comment,
If
but
you'd please identify yourself by at least the first name, if not more.
My name is Rose, and is this working?
Yes, use it.
Okay, that's better. Okay. Your comments about detox. In other venues, that is used in a different way. It's used to take medication from people who have intractable pain. And then they're denied it, they're denied their medications, and some terrible things can happen if the emergency nature of detox is not always addressed. When detox is suggested, that person should still have access to their regular medications. And in most venues, that does not happen. And if it gets denied, then they get denied their medicines, they get denied their detox. And in the case of the person I'm assisting, they had a heart attack when that happened. So there is some problem with that. And then I would like to talk about the pain scale, because it's like when a person has an accident and you ask them, did you lose consciousness? That's the wrong question to ask them, because they don't know. People who have pain oftentimes cannot quantify it in a number. When they're in pain, they don't think the way other people do, and they may talk about that number in terms of a different time. And if they're always on medication, saying, what is your pain like when you're off the medication, you can't do that. And people get denied their medication because they can't give the right answers to that question, or you didn't have enough improvement, therefore you should be denied your medications. So it's a vicious circle, it goes both ways. And some people who do have a valid reason to have pain medications are suffering because other people who don't get all the attention.
Yeah, well, they're suffering because of people like me.
Yeah.
I mean, not now, but that really, that's the people they're trying to stop. And the sad part is we are the ones who know how to work the system. We know what numbers to give. We know what to say. But you're right, I think, when it comes to sharing the burden and the doctor and the detox working together. But I can also say from the perspective here, I work with a company called Pathways Recovery. And I work with them from time to time. And there was a girl who came in who was addicted to methadone, and she wanted to get off of methadone. She had been prescribed pain medication that she tried to take herself off of, and her thinking was, I'll go on methadone because that's what everyone goes on, and then she didn't realize how hard it would be to get off of the methadone. So here she had insurance, full coverage with Cigna, and she wanted a detox, and she started the detox process like you talked about. She started going through the withdrawal, and she got into the facility. And everything was set up, and this is the letter Cigna sent. That a licensed utilized review agent, so somebody sitting at a desk, has determined based upon information that your symptoms do not meet Cigna behavioral medical necessity criteria for acute inpatient detox. That's for methadone withdrawal. So we have a patient fully covered whose insurance is deciding not to cover them. And my question is this: is this because they're drug addicts? So can we just throw them away? Because if we're going to do that as a society, let's collectively agree to that and then make it public. If we're going to toss them, we're going to better luck on the next generation. At least we're being upfront about it. But it feels like we're sort of we're not going to cover them. If this were heart disease, would they decide not to cover it? If this were high cholesterol, would they decide not to cover it? But because it's a drug addict, they decide not to cover it, and they determine that her symptoms don't meet that criteria. So I don't know what symptoms would if a methadone withdrawal doesn't. So that's what I say. The insurance companies have to be a part of this.
You've touched on, I'm going to cut you short for the sake of time, but you've touched on one of Ms. Yaroslavsky's pet projects, so that will be part of our evaluation, the whole process going forward. Were there any additional questions before we move on? Well, great. Well, thank you very much, sir, for your story. It's been very helpful.
Were there any comments from the phone
Yeah, thank you.
or questions?
There are no comments from the phones at this time. As
Great.
a reminder, it is star one.
Thank you.
Great. Next, we have Ms. Julie Nagasako to provide us with an update on the prescription opioid misuse and overdose prevention work group. Last year, several state entities got together, led by the California Department of Public Health, to talk about this issue with the goal to bring all state parties to one table to work together on eliminating opioid misuse and abuse, and more specifically, opioid overdose and deaths. Ms. Nagasako is going to tell us about that group, what actions they have taken, and what future actions will be taken. Please, Ms. Nagasako.
Thank you so much. Can you all hear me?
Almost like magic, and there you were.
Great. All right. Well, thank you. I'm so pleased to be with you all today to give you a brief update on our sort of about a year now in formation prescription drug misuse and overdose prevention work group. This is a group that functions at the state level with state partners at this point, but we want to do further interface with other stakeholders as well. So I work in our California Department of Health Director's Office. This work group has been an outreach of our director. Our former director, Dr. Ron Chapman, was the catalyst to help us reach out to partners and convene this group. And now our new director, Dr. Karen Smith, will be taking over the facilitation of the group. I think you're mostly familiar with the background. We know CDC declaring the prescription drug epidemic in 2013. For us in public health, our national organization of health officers issued a challenge inviting states to commit to reduce levels of misuse and overdose in their states. California joined that challenge, and part of our response to that was recognizing the need to bring together at the table the many different entities that touch this issue. And so we started that process last year. The purpose of the work group is to decrease levels of misuse, overdose, and death, to promote collaboration and joint efforts, and in particular, we think there's a lot of opportunities to collect and analyze data to help us inform that educational outreach that we're talking about, as well as program and policy efforts. The major strategies, one of the priority audiences that I want to draw attention to that we've been focusing on during our first year has been the need to talk with providers, health systems, and health plans to try to understand, as Jason shared, the system impacts that influence these situations. We really think, in particular, our state agencies are in a role where we can have a lot of productive dialogue with those entities. This is the structure of our work group at this stage. We have three major areas of focus. One is data, another awareness, and the third as policy. The data piece, we've established an interagency data group, which includes subject matter experts from the data perspective from each of our participating partners. And we've also launched a collaboration with the California Healthcare Foundation to do some mapping of that data. So, for example, initial maps that we hope to release include prescribing data that comes from cures and overdose data that comes from CDPH vital statistics. So putting those two data sources together on a page, looking at how that maps out across California, we think that could be a helpful tool to help our partners target activities as well as to help raise awareness about where impacts are the highest. It's complicated data, so that has been something that we find a lot of value in bringing together folks to look at it and analyze it in great detail, because it's not the simple picture that I think folks often expect. We also have an awareness team that's helped us with some messaging efforts, which I'll go into greater depth on. And then our sort of next on the horizon event is a stakeholder discussion team. As I mentioned, the work group itself is currently state agencies, but we recognize that there's so much happening at the community level and also within health systems and health plans and other stakeholders. We want to establish channels like this to help interface with those efforts so that we can leverage all of our work together. And the policy side is our trajectory is to start from data, work with many partners, and then work together to help identify what are the most effective policy interventions that we could support collectively. Here are the current partners that are participating in the work group, and it's been so exciting and inspiring to see how each time we gather, there are just more people who want to become a part of that dialogue. So as you can see, it's healthcare folks, public health, Department of Justice, Department of Education, Consumer Board, we have the Board of Pharmacy, Medical Board, Dental Board, and also now the Board of Registered Nursing, EMSA, Workers' Compensation, Department of Corrections, Managed Healthcare, Board of Insurance. So there are many, many partners, and we know that there are many more, but this has not been the kind of work group effort where we've been really having to chase people to participate. When we've introduced this issue area, people have really flocked to the table, and it's, I think, really speaks about the height of attention and concern about addressing this epidemic and the commitment to identify solutions. So our first collective awareness activity really emerged to help support the work of the medical board in launching the new pain management guidelines. It was this sort of perfect alignment of efforts that the new guidelines were coming out towards the fall of last year, and the work group had sort of coalesced, and we thought, what can we do to help promote awareness of these guidelines through all of our different channels to our respective audiences? So we tried to leverage our existing communication tools, stakeholder emails, a joint news release, try to bring in media coverage. We set up a web page on CDPH hosts the web page for the work group itself, but then has links to pages on each of our partners' web pages that address similar content about safe prescribing. The link to the website is here, but here's an example of how the Department of Education, also talking about prescription misuse and abuse, but their top statistics are about the impact to teenagers. The Board of Pharmacy has some great PSAs, so we had links available there that folks could interface with. So just common themes on our various website pages, or one of the communication tools we used. Here are some examples of those PSAs, including celebrities in the room, and then some coverage we got on television, as well as links available via YouTube. So trying to leverage some of the great materials that we've all worked on in our respective fields, and trying to help more people and bring more eyes to all of those. I spoke briefly about the interagency data group. We think there's really an opportunity there. So sort of our two main lenses are looking at the different data we collect in each of our fields, and then also I think we all see cures as one of the primary sort of critical data sources that helps tie all of this together. And we're working very closely with Mike Small and the team that's doing the upgrade to the cure system to hope be able to make available more effective reporting and more specific analysis that can help us understand prescribing patterns better and target opportunities for intervention. I mentioned the opioid data mapping project, and then one of the other projects that this team is taking on is trying to identify the risk factors for overdose fatality. And I think, again, that's helping us separate out the image of a drug addict on the street versus a person who may not be as readily identified. How do we know from the many millions of people that are being prescribed opioids which are at highest risk? The guidelines talk about different levels of dosage and duration that are of concern. Are there other risk factors that we could identify that could help us flag patients earlier to provide them with additional support, or to help physicians identify that need? And is there training that we could help pull together collectively that would help reinforce that? Next steps for the work group. I had mentioned we have a goal of hosting an event that would look at that upstream audience of providers, health systems, and health plans. So that's on the horizon, but not yet scheduled. We'd like to launch the initial, the heat map that I was describing, where our first set of data is prescribing data and overdose death data. We'd like to make it a series where periodically we'd be posting new maps, perhaps the next one being focused on treatment access, and utilization. So again, using all of our different partners, provide those data sets to introduce different lenses on the problem, and then make that available for both analysis and awareness. So then again, I mentioned the local efforts. We want to do more to help reach out from our state level partners to our local partners and see how we can work together. And then we want to, in all of our awareness activities that we do and any outreach we provide, encourage people to return to the pain management guidelines as a resource, because they really are very comprehensive and do have a lot of information in there about a lot of the concerns that were raised today. How do you help people to safely transition? How do you identify risk factors? So making people aware of what that resource is, both providers that we may communicate with, as well as for us, an audience like the local health department. How do they in their outreach know about that resource and can make it available to folks when they may inquire? And then that next step is looking at what we're describing as our phase 2 audience. We know that there's an importance of the phase 1 audience of providers, health systems, and health plans, but we understand that there's also a need to conduct public outreach around norms about pain management and helping the public to understand and have more productive dialogue with their providers about managing their own pain. So that's what we think would be something that we would conduct in the next phase and start the work on developing that now. We want to be very intentional about using data and research to inform that messaging, because we know that public messaging can have very significant impacts, and we want to make sure that we're cautious about that to make sure that we don't have unintended negative effects where people stop using medication that they should be using. So it's always this trying to take a very data-driven approach and identify what the most effective pathway is for that. So, all right.
Thank you, Ms. Nakasak. Would anyone like to ask some questions? Please, there's a hand raised, and you'll get a microphone in a second. I can't compliment you enough to let us know about what's been going on. It's nice to know that something positive is coming out of all these meetings, and I look forward to further updates. So thank you
so much.
Before we move to public comment, might I suggest you reach out to the Physician's Assistant Board, because they're also at the forefront, and I'm a member of that board, and I'll bring that up as well.
That would be outstanding. Thank
The
you.
nursing board is part of this also?
Yep.
Nursing board?
Yes,
Okay, good.
they've just joined us this year.
Hi, good to see you, Julie. Scott Clark, California Medical Association. And I just wanted to note some really nice synergy there that I heard. First from Ms. Jaroslavsky talking about how we're trying to find that balance point again to keep that swing from happening. But Mr. Smith from talking about addressing and identifying both. We have this stigma related to addiction as well as a stigma related to pain treatment. We have to balance these dual stigmas. We have to balance this pendulum between what's appropriate prescribing. I think if we've learned anything from our process so far, it's extremely challenging to manage all these things, all the while, especially while insurance plans or law enforcement are also putting a careful eye on the medical field. So your last point about the importance of messaging, I want to reinforce, and I know you've said there's going to be some stakeholder interaction happening, but I think it would be really important to, before you release the heat maps or another stage of information, to interact with the non-state agency audience, so the pain community, practitioners who are outside the state agency, to kind of help as a sounding board as to how are these messages going to play out in the real world. And so I just look forward to that opportunity, and hopefully we're going to get that chance soon. I think with the medical board guidelines, we saw there's a lot of great people in this room who can provide a lot of good input, and so hopefully we have that chance as well.
That would be great. Thank you.
Thank you. Any other questions or comments, please?
Hi, Maggie Buckley from paincommunity.org, and I'm a patient advocate, and I just want to remind everybody in this room that while Jason's story is compelling, and you hear that just as often, the people with valid pain conditions and long-term pain conditions like myself who have had need of opioid medications, myself since 1974, off and on as part of an overall treatment plan, without stakeholder input from my group, we end up being vilified, criminalized, and we often suffer, not just in the medical sense, but also as targets for crime or investigations by law enforcement, et cetera, which is really unneeded. So I would encourage everyone in here to maintain a balance, keep those of us from the pain community involved all along the way, just because we don't have a state agency that represents us. And unfortunately, many of us are not willing or able to speak up because of the bad treatment we've had to suffer in the last 30 years. I'm available to talk and interact as well.
So to that comment, I just want to remind the audience, and both here and not here, the gift I've had of serving on this medical board for the length of time I've served is I've seen things go almost full circle. So from the time where we had law enforcement, media coverage, horrible outcomes for people that really needed the medications, the medical board did convene an intractable pain task force. And at that meeting, that was the beginning of our pain guidelines that have been reviewed and updated. But at that time, it was pure and simple. Good faith exam, appropriate plan for review of that plan for the doctors, those doctors that are prescribing huge amounts of medicines to keep those patients in a position where they need to be kept I'm sure they're not without pain, but painless, meaning not without pain, but less pain, has taken place, so that we've hopefully taken care of that portion of the problem. Intractable pain is not part of this discussion. To my knowledge, this is about people that are dying, more like we heard, he's still alive. But the media is quick to promote those that die.
But because of that situation, for example, a 38-year-old woman died on March 15th because of lack of access to pain care. And I appreciate what you're saying, Barbara. I've been involved in the process with
Right.
the medical board and this task force all along. And I understand that. It's just surprising to see another effort that comes forward and they talk about involving all the stakeholders. And the biggest hole that I see is that there's no patient interaction in there.
So I'm going to turn the microphone over to our Executive Director, Kim Kirchmeier, who has been totally involved in this process and is totally aware of what issue you're bringing.
And I think, Maggie, I think that's a great point. There is no state agency actually for the patient per se. And I think that's something that Julie and I can definitely talk about and look at their involvement. Definitely when we open it up to the stakeholders for that work group, obviously we want to make sure that you all are involved. But I think that is an interesting concept that we don't think about on the side of the boards, is that there isn't a state agency, you know. So maybe it's even a ombudsman, or maybe we can reach out to some of those individuals who we can maybe get involved. So I think that's a good point as well.
Another entity, so I'll just add a couple comments, is that we have engaged along those lines is the Office of the Patient Advocate. And so that's one. And part of their dialogue with us was trying to understand whether it makes sense for them to participate as a member of the work group or to respond to and provide feedback to the work group to help maintain that appropriate role. So, but we want to have them in the conversation. I just want to reiterate that it's just a building process for us. This initial year, we felt that there was a lack of understanding and communication between the state agencies about what each of us does that had to be addressed sort of as a foundation before we could understand and start to go out for broader stakeholder interaction. Part of why we felt really comfortable promoting the medical board guidelines is because there was a robust stakeholder involvement process. So our goal for this year is to begin that stakeholder outreach process. And so there will be a piece of that will communicate through these channels and through all of our partners. That's the great thing about having all of them there. But let's chat afterwards as well.
Okay.
Hello, Rose again. I think a part of that process needs to involve the actual people who are able or their advocates.
Mm-hmm.
And one of the things that's happened is assumptions that come from the new guidelines, because the still existing B&P and H&S codes regarding intractable pain and treatment for persons who are not able, for whatever reason, to remove themselves from that safely, whether they're addicts, abusers, or they have no choice.
Mm-hmm.
By removing the words intractable pain or leaving that delineation out, it makes it look as if these laws went away and those rights that go with it went away.
Mm-hmm.
And what those laws do is they establish the concept of medical necessity for those treatments, whether it be detox or tapering off, or the appropriate use of the medications. And when the words go away, everyone assumes the laws have changed and it's different. But the laws have not changed. So I think we need to make sure that references to the laws are still there, because those contain protections for both sides of the spectrum. And then nobody's left out. And I would be interested in participating in any of the future events as well.
Great, thank you.
I would suggest that when everybody gets ready that was on that list to involve the next layer or the next generation of participants, that every single entity that you saw out there is going to do some kind of a coordinated effort of doing outreach. So I would just urge the people here to make sure that people you know or that you for sure are are taking a look at the websites so that you'll know when these things happen, and you can then be guaranteed participation if you want to participate. Does that make sense? Okay, so we're going to thank you very much.
Thank you.
We're going to move on the agenda.
Do we have any questions from the phone?
Oh, sorry, it's phone questions. Do we have any phone conversations going on, period?
We have no questions from the phones
On
at
the
this
phone
time.
line?
As a reminder, it is star 1 to signal.
Thank you.
Thank you very much. So along with us today is Dr. Rupali Das, who is the Executive Medical Director of the Division of Workers' Comp. Dr. Das is going to update us on the status of the Division of Workers' Compensation guidelines and also provide any best practices that the department is using regarding this issue. Thank you, Dr. Das.
Good morning. Thank you for inviting me here to speak to you today. My name is Rupali Das, and I'm the Executive Medical Director for the Division of Workers' Compensation, and I'm very happy to provide you with an update on the division's work on preventing prescription drug misuse and overuse. The division's mission is to minimize the adverse impacts of work-related injuries on California employees and employers. And the issue of prescription drugs, as you all know, for the treatment of pain is of special relevance to the treatment of injured workers. In this population, chronic pain resulting from work-related injuries years or even decades ago is prevalent and poses a particular challenge. And of course, workers get injured and acute treatment is also of concern. I believe we need to approach this challenge with a multidisciplinary approach, and that's what our guidelines recommend. I'm an internist and occupational and environmental health specialist, and consistent with my training, I believe that the most effective approach is actually prevention of the injury in the first place. For example, through workplace design, health promotion, and worker and employer education. But workers do get injured, and when work-related injuries do occur and patients seek medical care in the workers' comp system, treating providers are required to use the evidence-based treatment guidelines termed the Medical Treatment Utilization Schedule, or I might call it MTUS for short during this presentation. A panel of experts, the Medical Evidence Evaluation Advisory Committee, provides advice on the development of guidelines. So these are experts in the community. Some of them are specialists in workers' compensation. Some are just general pain specialists. We have a multidisciplinary group that's been meeting for several years. The regulations for the treatment guidelines and the committee are set forth in regulation. All of our regulations, including the treatment guidelines, go through a public comment process before being adopted. So during that public comment process, we encourage people to provide written comment as well as come to our hearings and comment in person. And we're required to respond to each of those comments as we adopt the regulation. So our activities with regards to this task force fall into three broad categories: treatment guidelines, education, and collaboration. So first, with treatment guidelines. Historically, the recommendations for opioid use have been in our chronic pain treatment guidelines. In late 2012, in response to the, as you all know, the well-known epidemic of prescription drug misuse declared by CDC, we made the decision to develop separate guidelines for the use of opioids for treating chronic non-cancer pain due to work-related injuries. But we address acute, subacute, postoperative, and chronic pain. But a lot of the guideline is really focused on the treatment of chronic pain. We worked with our advisory committee and released a pre-rulemaking, or it's called informal forum posting last year. And we received several comments, and that's an informal posting, and we're not really required to respond to those comments. But we took a look at the comments. We made several improvements and changes in response. And we have a revised version that we're hoping to release later this month, and that will start the formal rulemaking process. Along with the opioid treatment guidelines, we will simultaneously release the chronic pain treatment guidelines because they really go hand in hand, even though they're currently separate. The first 45-day comment period will end with a public hearing in Oakland, downtown Oakland, and we encourage you all to come and provide your comments, even if you're not an injured worker or if you don't represent injured workers. We want to hear from everybody, and also provide written comments, which we are required to respond to. So as I said, primary prevention is my real focus, but when primary prevention hasn't worked and an injury has occurred, our guidelines recommend secondary and tertiary prevention, that is, to promote best practices and reduce harm from occurring due to treatment. In the context of this task force, this means several things, and I'm just going to go through an outline of what our guidelines contain. First of all, preventing unnecessary use of opioids. So we agree that opioids have their place in treating pain. And I'm just referring to acute pain right now. But we think that physicians really need to consider the whole patient, perform a comprehensive evaluation, not prescribe them for acute injuries unless they're really necessary for treating severe pain that's not controlled with non-opioid modalities, and restrict their use to situations where pain is severe. Use them at the lowest effective dose for short durations and without refills. Again, this is for acute injuries. Exert caution, and we prescribe or recommend several situations where caution should be prescribed. That is in the presence of certain comorbidities, asking about contraindicated medications that are being used simultaneously, like benzodiazepines, notifying patients about potential adverse impacts. I know that when people go to the dentist, they're often prescribed opioids without notification about adverse impacts. I think patients should be cautioned a little bit more about potential adverse impacts. Documenting progress in the medical record and continuing opioids only as medically necessary, and we recommend measuring pain and function. It's difficult to do, but I think documentation needs to be provided in the medical record that provides the reason that opioids might be medically necessary. Monitoring use through cures at all phases of treatment, and conducting urine drug testing when appropriate. Now, urine drug testing we recommend when people get into the subacute and the chronic phase of treatment, but depending on the patient, urine drug testing might be indicated even earlier. Importantly, our guidelines encourage multidisciplinary treatment of pain. So it's the pain, people have pain, it needs to be treated, and we're restricting medications. We need to provide other forms of treatment. This includes appropriate physical activity, physical and occupational therapy, cognitive behavioral therapy, and alternative treatments that have been proven to be effective, like yoga, acupuncture, and other forms of treatment. In addition, consultation with a specialist might be needed, and we recommend that, for example, an addiction specialist for help with weaning regimens, but other specialists might also be needed. We recognize that there are a subset of patients with chronic non-cancer pain who are already being treated with chronic opioid therapy. And of course, where we have a special section dedicated to them, we don't recommend cutting off opioids in these patients. Patient welfare and well-being are always the priority. This includes pain control and functional improvement, and also weaning as opposed to abrupt discontinuation. But we recognize that in some patients who've been on chronic opioids for years, it may be difficult, if not impossible, to get them completely weaned off opioids. We make several mentions of weaning rather than abrupt discontinuation because this has been an accusation that's occurred in the workers' compensation arena, that patients are being abruptly discontinued from opioids, and we don't want that to happen. While the bulk of our recommendations were based on a thorough review of existing opioid guidelines, where there were gaps or new literature, we referenced original studies. Particularly, we looked at 3 studies that were recent and high quality and looked at the dose at which adverse impacts occur, and we developed our threshold based on a review of these original studies. The 3 authors are Bonert, Dunn, and Gomes, and the authors are available in our guidelines. Our opioid threshold is consistent with the medical board's threshold, and it's 80 milligrams per day morphine equivalent dose. While there is no safe dose of opioids, the risks of adverse impacts increase with higher doses, and our threshold is the dose at which, based on the literature, we felt the risk curve sharply rises, and the risk of adverse impacts outweighs the risk of benefits. So again, we don't recommend abrupt discontinuation, but that is the goal at which patients should not go above if they're not being treated with opioids, or there should be attempts to get them below that if they are already on opioids, with all the caveats that I already mentioned. Our second major approach is education. We've been focusing on developing the content of the guidelines, but we're going to shift to providing education, and we plan to conduct a campaign to educate providers, hopefully in collaboration with the Medical Board and the California Department of Public Health and other professional organizations, to train physicians and others about our guidelines and the appropriate use of opioids. And finally, collaboration. I'm really grateful to have the opportunity to work with the Medical Board and also with the California Department of Public Health. I've had a conversation with Julie Nagasako on the phone, and we really look forward to harmonizing our recommendations to coordinate resources and efforts across the state. Specifically, as I already mentioned, the threshold for the Division of Workers' Compensation and the Medical Board are consistent, so I'm really happy that the state of California has a consistent threshold. And more recently, we've been working with CDPH on their statewide efforts to curb prescription drug overdose. For example, one of the unique things we're doing is looking at our data set where insurers report treatment provided to patients and looking at that work comp data and looking at how that might be used to target interventions. For example, where are the most prescriptions and the highest prescriptions being given in the state. I'd also like to take this opportunity to thank the incredible staff that I work with. I'm representing their work. They're really dedicated to helping workers, and I'm really proud of their accomplishments. And I look forward to continuing to work with this board in the future. Thank you for this opportunity.
Do we have some questions? Dan, please, you need a microphone.
Good morning. My name is Patricia Hine, and I'm with the California Department of Insurance. Thank you so much for inviting us to be here today. I'm so pleased to be here. Just to provide a perspective of how big workers' compensation is in California, as of 2013, 500,000 employers funded workers' compensation benefits in California. And insurers wrote $14.8 billion in premium, which is 1/4 of our country's premium.
Wow.
Now, at the CDI, California Department of Insurance, one of our roles is to ensure vibrant markets, vibrant insurance markets in California. And so we closely monitor cost trends in the workers' compensation system. And medical costs have been a major cost driver. We looked at some of the statistics from the California Workers' Compensation Institute, the CWCI, and they have quantified the extent to which opioids have become a major cost driver in California. The CWCI determined that payments for opioids increased from 4.7% in 2002 to 19.6% in 2013. Which represents 1 out of every $5 paid for workers' compensation prescriptions in California. Of course, the personal toll that opioids take on injured workers and their families is incalculable, but we just want to express our support for the collaboration between the state agencies, and I'm delighted to hear from Dr. Das and to see her participation with the Medical Board. In listening to Ms. Nagasako's presentation, I can't help but wonder if there might be some data within the workers' compensation system that might be helpful in your mission. Thank you so much.
Thank you. See some hands in the back. Thank you very much.
Hi, Maggie Buckley from paincommunity.org. Dr. Das, I'm very encouraged by your report, and I want to thank you for emphasizing the multimodality treatment, et cetera. That is one of the things I know because I've spoken to Barbara before about the gap between what insurance covers currently and getting to the ideal model, which has been my life experience in managing pain, which is the multimodality thing. So I'm glad that there's an insurance representative in there. And again, thank you so much for emphasizing that, including it, underscoring it. I feel like after 25 years, somebody's been listening to the groups of patients out there asking for that. So,
Thank you for your comments, and I encourage you to come to the public hearing and to provide comments to that regard.
So thank you. I don't see any other questions. Oh, a phone conversation, phone questions?
Do we have any questions from the phone?
We have a question from Gerald Bryant.
Great, go ahead.
Caller, please check your mute button. Your line is open.
Go
We
ahead,
have no
caller.
response. We have no further questions.
Okay, thank you.
One more?
Yes. Rose again. With the MTUS manual, when the MTUS manual, when the chronic pain guidelines came out in July 18th of 2009, are you aware that there are utilization review companies that have, in place of those guidelines, developed their own guidelines and have been using those consistently since then when they are reviewing patients with chronic and intractable pain?
We are, in response to that, let me just say that we are just about to put into regulation a new framework that sets the baseline of how the treatment guidelines are supposed to be used. And while utilization review companies always were supposed to use the medical treatment guidelines, that it wasn't very clear on what they were supposed to do, but the new regulations that will go into effect probably this month will make it very clear that they need to start with the guidelines that are really put out by the Division of Workers' Compensation.
Okay. Well, those guidelines very clearly stated that policy on pages 6 through 10, which included the medical board's policy as the number one policy, because that's a California policy that was already in effect when these guidelines came into place. And it also gave references to Business and Professions Code 2241.5 and Health and Safety Code 124.960, which are the chronic and intractable pain rights. These are left out consistently. You will not find references to those pages or the pages for ongoing treatment in utilization reviews, in the determination letters from independent medical reviews, because they are just not being put into their computer protocols for making reviews, which makes a month and after month after month roller coaster when persons are supposed to be receiving continuation of their care, and to get that care timely, without interruption, without going into withdrawal, and if you go into withdrawal, you get denied because you went into withdrawal. It's a catch-22. Somebody has to pay hundreds and hundreds of dollars every month for them to get their medications, while utilization review is going on, reviewing it, saying that they need to be weaned off of the medications that they will never be weaned off of. The new medical board policy on page 1 very clearly says this was not intended to deny people who have an ongoing need for pain medication. You yourself have said the same thing. It's not meant to deny these people their ongoing pain medication, but that's what's happening because nobody is referring to the correct guidelines or the correct part of the correct guidelines.
Okay, I'm going to have to interrupt you and suggest that you need to go to their public hearing
Yes.
on this matter because you definitely have some important points to raise, and thank you.
Thank you for your input.
Thank you.
Okay, we are going to now move to Ms. Kirchmeier. She's Executive Officer of the Medical Board of California. And I'm just going to turn it over to her without further ado.
Well, I'm going to be providing an update on cures, but before I get there, I do have to clarify something I said earlier, something to regard to what Maggie was saying, is that obviously, and I'm looking, I have several other executive officers in here from other boards, and I'd be remiss if we didn't say that though there isn't a state entity that particularly identifies physicians, all of us are consumer protection agencies, and so our goal really is consumer protection when we're looking at it, and so it's important that we look at it from both perspectives of the individual who is having pain as well as those who are being inappropriately prescribed medication. So I did want to state on behalf of all the state entities here in the room that that's absolutely our goal when we're looking at anything, is to identify the best for consumer protection. So I'd be remiss if I didn't pass that on. So in regards to the cures system, as all of you may know or may not know, the Department of Justice, in coordination with the Department of Consumer Affairs, is working on updating and improving the current cures system. For those of you that are enrolled and use it right now, some of you will know that there are significant delays sometimes in getting information or even getting registered, and so that's hopefully going to come to an end. The rollout of this new system is actually scheduled on July 1st of this year, so July 1st of 2015, and the intent is to have the system going so all prescribers and dispensers that prescribe, order, dispense controlled substances will actually have to be registered by January 1st of 2016. So the goal is to make that happen by July 1st so everybody can meet the goal of January 1st. Right now, at this time, a significant amount of work has gone into this new system. Information's been gathered, and the system actually has now been designed. Staff from our board are actually meeting with the Department of Justice and staff from other boards to start training and developing test scripts. The next step on this project is that user acceptance testing is going to begin in May, and the actual testing is scheduled to go from about towards the middle to end of May all the way to the middle of June. Now, even though these testing dates are pushed, we've pushed them up a little bit and they're close to that go live date, the Department of Justice is still confident that they will be able to make the July 1st date for rollout. In addition, the involved parties have begun putting together an outreach plan. This plan will actually involve notifications to all licensees via email, social media, newsletters, and notifying other organizations such as the California Medical Association, California Pharmacy Association, and all of the associations from the boards, notifying them to get information out to their licensees as well, and I believe a lot of the associations have already done that. The Department of Justice will be working on drafting information regarding the new care system, and then we will be disseminating that information to the licensees and the associations and organizations. The material is going to include information on who needs to register, the registration process, how to look up patient information, how to enter information for licensees who direct dispense, and other important information. The outreach plan also includes a post-launch information as well. Now, the board actually is currently assisting individuals in getting registered. We knew that this deadline was coming up, and we know that in the 6 months from July 1st to December is going to be busy. So what we're trying to do is make a dent in that right now. Just for the medical board, we have approximately 130,000 licensees. All of those don't prescribe controlled substances, so you're probably looking maybe, I don't know, Scott, do you have an idea of how many of those? Maybe 100,000, I would say. So 75,000 in California, probably. So 75,000 of those individuals. So what we're doing right now is we're actually, in fact, on Thursday evening, I'm going to be at the Methodist Hospital to assist individuals in signing up for cures. Right now, there's a requirement that you actually have to have the documents you have notarized. So we're actually going out from the medical board, the pharmacy board's doing the same thing at events, and then our signature is working for a notarization as long as you bring, as a physician, you bring the appropriate information. We also accept applications as long as you have all of the information here in our board offices and during any of our board meetings statewide. We've been doing that too as well. So we're trying to get everybody signed up for cures by that January 1st, 2016 date. Again, the goal isn't to get everybody registered because, well, that's legislatively mandated. the goal is to get physicians using the system, and that's really where we're going to be pushing our outreach from our perspective, is not that everybody gets registered to meet the mandate that's been put into law, but if you are a prescriber, that you actually use the system and know how to use that system. We've seen, I think the pharmacy board has a good example of an individual that I think, and I'm not going to get the accurate numbers, but an individual that was actually seen by 18 different prescribers within, I think, about a 30 to 60 day period. And if one individual, just if one of those individuals would have actually looked up cures, it would have stopped that individual from being able to doctor shop. So that's really what we're going to be putting into our outreach, as well as the registration. So I think it's a two-step process. So that's the information I have on cures, unless anybody has any questions on the update. Yes.
Question in the back?
Jason Smith. The question, not so much on the update, but on the concept when it comes to mandatory registration. I'm unclear what the point is if we're mandating that they register but not use.
Yeah, the process really is for now to get them registered. Obviously, through any legislative process, there has been opportunity to put in requiring an individual to do that. However, at this point, that legislation has not passed. What has passed, though, is the mandate for them to actually register in the system. And so just to go to that, Jason, that's kind of why our push is not just to register, but to actually use the system. It is not legislatively mandated right now, just because the legislature hasn't passed a law to require that yet. Whether it will in the future, that's up to them.
Any other questions? I see another one.
Hi, my name's Jamie. I'm an ER physician from LA. I just had a quick question. So what is the user end changes that we should expect to see on cures? And you might have touched on it in broad strokes, but right now using it, there's a 2 to 3 week lag in the prescriptions that get loaded. So is that going to be addressed with the new update? Additionally, it's pretty user not friendly. Lots of times when you look up a patient, there's 10 entries with the same name and you're not sure which one of those to click. So is that going to try and meet that out with the update?
Definitely for the user friendliness of it. And unfortunately, I haven't seen, I'm looking at Ms. Carrasco in the back. I don't think that we've actually seen the end result yet of what it's going to look like. I know that that's still in the design phase. But for user friendly, that is the whole goal of this, is to meet that. The 2 to 3 lag time, there will always be about a week lag time, because the pharmacist has 1 week to be able to put that prescription in. Other than that, we've been told that it's about a 24 to 48 hour time frame to get that information in. So at the most, an entity would have, if you're looking up an individual, you could have 1 week lag time, basically 8-day week time lag, just because of the way the law is written right now. So the 2 to 3 should not be occurring. Because they're required, they're mandated to report that information in 7 days. So hopefully with the new system, it should work well enough that there is no lag time, other than if there's a problem with one of the prescriptions.
So I have a follow-up question to what I've just heard, and that would be, within the user group that's going to be going forward in May, correct, to see if the cures application is one that functions and is usable. Are doctors being included in that?
As Scott knows, I know. We've been very vocal because of our issues that we have with systems working, that we have been very vocal that the user of the system needs to be involved in this testing. So we've actually reached out, and I know the Department of Justice has reached out to the California Medical Association, California Pharmacy Association, and actually Dental Association, all of the prescribing boards, to ask them to send users that would be involved in the process. And I'm sorry to put Mr. Clark on the spot, but you guys are sending individuals for the testing as well, correct? Yeah, so they're involved.
So I would just hope that emergency room doctors would also be included, because I'm hearing they are. Because otherwise there's someone in the back that I want to make sure she's at the table.
Yeah, California ASAP has a number of members involved in the process.
And they're showing up?
Yes.
Good. I want to make sure if they have to use it, they might as well be there.
We hopefully learn by past mistakes.
Thank you. Okay.
Anything more from the audience? One more? Yes.
Yes, and yeah, thanks to the Medical Board and Department of Justice for incorporating us in the upgrade process. I'm always anxious. I'm like, what's next? Come on, can I see the next thing? But understand things have to go through a process. So we look forward to the next phase. But one of the questions that I have, and Kim, I don't know if you know the answer to this, but I've heard some different things on the streamlined registration aspect, which is so important to getting people registered in time, and the difficulties with the Breeze system implementation, perhaps throwing some wrenches in that process. And I was wondering if you could talk a little bit about your understanding right now.
I can actually. We just have finalized the registration process. I think as close as we're going to be to getting it automated right now with the Breeze system. And actually, we're working with the Department of Consumer Affairs, and so they're going to interface the two entities together to where they're going to check once the individual registers. It's going to, for lack of a better word, ping over to the Department of Consumer Affairs for that individual's licensing information and then go back to the Department of Justice. So all of the bugs, I believe, on that had originally been thought that we might have them, those have all been worked out now. So we should be able to, once an individual goes in and registers, there should be a very short time delay in getting that individual finalized in the system, because we are communicating and interfacing our information with the Department of Justice.
My name is Jason. I'm sorry, one last question regarding the cures. And just to sort of touch on what I touched on earlier, cures is going to catch people. It's going to do its job. It's going to cut people off of medication who were doctor shopping, or it's going to catch doctors who were over-prescribing. It's going to catch all of these things. Is there anything built into California's PDMP to catch these people? Because I understand cures is a database, but there is logically there's going to be some fallout on the people who will not be getting what they're used to getting. And is there anything in place, or is that just someone else's problem to deal with? All we are is data.
How do I answer that? Basically, you're absolutely right. What's going to happen is, and as more individuals use the care system, they're going to identify individuals who are coming to them. I believe in our guidelines, we cover the fact of when you have an individual that comes to you, how to appropriately titrate those individuals off. And we would recommend any physician to actually follow the standard of care if they had an individual that came to them and who was addicted to pain medication. We would encourage any doctor to make sure that they follow through on the appropriate steps, whether it's referral to an addictionologist, referral to the appropriate parties. But again, just as you said, Jason, to be quite frank, there are more parties in this room that need to be involved in that process, because we've heard from other entities that treatment needs to be covered. And a lot of times individuals run into problems without being able to get their treatment covered, depending on what coverage, health insurance coverage they have, or other entities like that. So I think that is where our work group needs to look at. But again, that is the bigger issue. You're absolutely right that it's meeting that demand right now. Yeah.
Are psychiatrists being included in the CURES program as well? Are they being into that? I mean, because basically I have a coworker, I work for an insurance company, and I look at pharmacy claims every single day. I see members that are getting 4 different prescribers and 4 different pharmacies, and I kind of learned how to work the system as well. Being on the inside, through depression, I turned to medications, opiate prescriptions, instead of realizing that I had depression myself. And I have a coworker that I shared this experience with, and she went through something similar. She went to her psychiatrist, who actually pulled up CURES and saw that she had been using opiates and benzodiazepines. And her psychiatrist was able to help her with treatment for that problem, because she was able to see that she had been using that. So I want to make sure that psychiatrists are included in that as well.
So a psychiatrist in the state of California is a physician and surgeon. So they have to hold that license, and then they specialize. It's their board specialty that makes them a psychiatrist, so, or their practice area. So they will fit into the entities that have to be, the licensees that have to be registered as of January 1st, 2016, and then encouraged to definitely use the system once it is more user-friendly. Absolutely.
Anything from the phone? No, is there one more? I'm sorry.
Hi, I'm Samir from UC Davis. I'd like to echo some comments in the room, but I think an important trend that we're going to see as hopefully we effectively manage the prescription drug abuse problem is that, yes, I do think that many of these patients will find other sources and unsafe sources, such as heroin. I think there's a recent, even more recent article than the one we saw in the New England Journal regarding heroin abuse. And that is going to be very dangerous, perhaps more dangerous than what we've seen. So, you know, one of the comments that I think that is important to note is, do we have enough access to addictionologists? And I'm not sure we do. I know, for example, that as Covered California and as, I guess colloquially, Obamacare comes in, that we are seeing a lot more patients, and a lot more patients that may not have good coverage, and that we might not get the access to what they need. And in order to prevent these patients to get to, or to go seek other sources to treat their addiction, I think that's something that needs to be addressed going forward. Another comment really quick is on the multidisciplinary aspect of pain. I think this is something that's extremely important. I will say that insurance companies, from my perspective, it's been very difficult to get some things approved that need to be approved, such as simple things, maybe cognitive behavioral therapy, acupuncture, yoga, you know, things that are very safe and I think are effective, but I feel I get a lot of pushback from those things. And I'm a interventionalist too. I do a lot of procedures, and you know, recently in the injured workers population, there's been some pushback for even doing things that are very effective that we've seen over the years, such as spinal cord stimulation for these patients that can get these patients off of opioids, or at least help them in other ways than opioids. So those are my comments.
Any questions from the phone?
We have no questions from the phones at this time.
Great, thank you.
Okay, great. So now we're coming to the portion of the meeting where we're going to ask from input from our community stakeholders. We've heard from the state agencies and others, but now we'd like to hear some more formal input from some of our community stakeholders. Again, we're looking for ways to battle the epidemic of prescription drug overdose from each of your perspectives. We want to hear those ideas and use them to provide education to our physicians and to the public via our newsletter, website, and other educational opportunities, and certainly perhaps to influence legislation and policy. So today, the first speaker is Dr. Gorman from Case Management Technologies.
Thank you very much for allowing us to present to you today. My name is Jack Gorman. I'm actually filling in for Dr. Christopher Rice, who I think you know very well, who couldn't be here today, but I'm from New York, he's from California. But we've worked together on developing a program that I'd like to talk to you about, that Care Management Technologies, which is a company based in Research Triangle, North Carolina. And the program is called the Opioid Prescription Intervention, and we began devising this a little over 5 years ago. The company actually operates in a public health and population health format, helping both public and commercial health plans to better manage prescription practices and other aspects of health care. And as been mentioned several times today, the key feature of this is to go through the overwhelming amounts of data that we all have to identify people who have special problems and need special attention. And in this particular arena, we are trying to identify people who are receiving prescriptions for opioids or not receiving prescriptions for opioids when that would be in contradiction to guidelines and best practices. And to track and measure using both data analytics and a system called audit and feedback to interact directly with physicians, other prescribers, and healthcare administrators. I'm not going to go through all of this because you know it all very, very well and have spoken about it already today, especially this idea that when I went to medical school, I once heard a surgeon say that the definition of minor surgery was what he did to patients, and major surgery was only if he had to have an operation himself. So pain was not at all in their vocabulary way back then. Fortunately, things have gotten a lot better since then, and there are many, many measures have been taken to try to improve recognition in the healthcare system of pain and the efficacy of opioids in treating chronic pain. And of course, we've also devised some problems because of that. Again, I won't go through that. But as also has been mentioned today, there is still, despite the great epidemic of overdose, a huge problem with the undertreatment of pain. And we know that undertreatment of pain has terrible consequences, including increasing mortality in patients who have it, and that it's getting harder for some people to get pain medications. So as has been mentioned many times, and as I know you all are very sensitive to, this needs to be taken into account from both perspectives. And one of the things that is very important always to keep in mind is that most instances of the misuse of opioids begin with a legitimate doctor's prescription to somebody. It may later become not so legitimate, but it usually begins this way, meaning that most of this is not the cases that we see on the front page of newspapers where there's a doctor somewhere who is selling prescriptions for opioids as a business and is involved in criminal activity. Very little of this is actually criminal activity. In fact, there was a study published in July, I think from a California sample, showing that the majority of people reporting to emergency rooms with opioid overdoses had actually overdosed on the medicine prescribed to them by their physician and within the past month or two. So that is the most serious source of this, even though there are other sources. Thanks to Dr. Rice, we have the opportunity to see these guidelines as you were recently developing them, and I actually made some comments on them and learned a great deal from them. So they're incorporated into some of what we call the quality indicators for this opioid prescription intervention plan, and hopefully we were helpful in this. There are many, many different solutions that are in play right now, including cures. I come from New York State, where it is actually mandatory that physicians do actually, by law, have to check before they prescribe any controlled substance. And there are early indications, as people have said, both that it is reducing the number of people who are doctor shopping. Some people are claiming that it is increasing the use of other illicit drugs. It's early on in the system, and the data are not fully in place about how well this works, how does it help, and what are the unintended consequences. But that'll be a very important source of data, I think, for you in California, where doctors are required to check. So what I really wanted to show you was PROACT, which is Care Management Technology's attempt to have one of the solutions. This is by no means the only one, but hopefully to fit into the many solutions that are being tested. And we hope that this will be sensitive to better education and better patient care. So it begins with data analytics, and this merely shows you that from what care management technology does is it takes all of the data that any health plan has, whether it's an entire state's Medicaid agency or a commercial payer, or as you'll see in a moment, the province of Manitoba in Canada, and boils it down into increasingly smaller and smaller sets that are increasingly usable, both showing in this particular case the costs ascribed and attributable to the prescription of opioids, and also the number of people prescribing opioids, the number of people getting opioids, very high level data from that, and then drill down to other data. So this is an analytic tool that is based on best practices, as you will see. It's devised by scrutinizing all of the guidelines on an international basis from countries all over the world, plus constantly surveilling the literature, to see as things change what needs to be added, subtracted, or changed in these systems and in these algorithms, and then to provide educational feedback to prescribers on best practices. Again, hoping to show doctors things that they don't necessarily know on their own, and then to give them very good advice on what they can do to help that particular patient, both in terms of determining whether there is a problem and then what to do with that problem. So again, this is the highest level that PROACT operates on. It would be appropriate to administrators at a healthcare system who can see right away. These are, on the left-hand column, what we call quality indicators. This is just a partial list of them, and identifies people for whom there may be a problem with the medication they're prescribing. So, for example, if a patient has broken his or her leg 3 months ago and is still getting Percodan, that will get flagged on the system, since most people believe and agree that that's not an appropriate medication 3 months after somebody has gotten. And it's amazing how often it turns out that, particularly in large practices, the prescriber isn't aware that that's been happening. And this is an example, and I think this was an example that the first speaker mentioned, of the kind of clinical consideration that clinicians get. And these can be done via email, by a fax, by a letter, whatever the system locally will have. Identifying somebody who's been getting an opioid and a muscle relaxant, in this particular case for 60 or more days, but it can be, the time frame can be changed to real time, one prescription, to longer time frames. As you see in the left-hand issue, it explains why that's often problematic. In the middle column, what some of the steps are, and in the right-hand column, what is the evidence for making that determination that this is problematic. And by the way, this works both ways, as I said before. So this system will also pick up. It turns out that many patients, for example, with cancer, stop taking their pain medicine and their doctors don't know about it. They often stop taking it because they have adverse effects, or they get embarrassed to fill it at the drugstore. This system will pick up on that too and advise a clinician, your patient with cancer is no longer taking their pain medicine. Do you think you want to look into that and see if maybe they should be, or if they should be on a different pain medicine? So it works both ways. This is an example of identifying someone who's getting opioids who is in a very high-risk group for misusing them, somebody with some other substance use disorder. And again, this does not say stop the medication. The clinical consideration that goes to the clinician says this, first of all, does not mean this person doesn't have pain, part of the double negative. They may actually need pain medicine, but you should be aware that this is somebody that may need extra surveillance because they're in a group that is at highest risk for misuse of the medication. And this is an overview that a clinician can get of all the patients that he or she has on opioids. So this operates both at the level of individual prescribers, to case managers and care managers, all the way up to administrators who are having the overview of the whole system so that they can see the entire pattern of opioid prescriptions. Very often, by the way, as we were talking before, by showing them the cost, they, for the first time, realize that the problem is not the cost of the pills themselves, which is actually trivial. So just showing somebody how much they're spending on the actual prescription is often, I shouldn't say trivial, but it's often not the problem. It's the cost of emergency room visits and hospitalizations that people on opioids frequently have, again, that often get missed by people looking at these total costs. This will also pick up on people who are making many emergency room visits who have painful conditions, people who ought to be seen as outpatients and get better pain management, or people who are going to emergency rooms getting opioids, which is also something that often is not something that primary care doctors are aware of. Now, I just briefly want to show you 3 examples of evaluations of this system. So this has been used in the state of Missouri by their Medicaid agency, so applies to all the patients in the state of Missouri who receive opioids. And Missouri independently looked at a period of time 1 year before the opioid prescription intervention was put in place in Missouri, and then a year after that. This is not a controlled trial, so this is simply a pre- and post-analysis which did show that there was a reduction in not just the number of opioid prescriptions, but also the average monthly dose of opioid and also the number of hospitalizations among people who were on opioids. This is a randomized trial done by a commercial insurance company called Gateway, in which they randomized clinicians in their system to either receive a care management technology opioid prescription intervention notification of one of these quality indicators or not. So this is a randomized prospective trial, that again showed a decrease in the number of people who were prescribed opioids in the absence of a diagnosis that justified the use of chronic opioids. Now, this is, again, a very interesting thing. I reviewed all of the people who received opioids in the Missouri Medicaid in a year once. And I think in 15% of the cases was there a diagnosis that had anything whatsoever to do with chronic pain. And I actually used a very, very liberal criteria for what was a diagnosis. Now, you can argue that many clinicians don't put down the diagnosis that the patient really has, and we hope that one of the things this will accomplish is encouraging physicians to do that, because we can't operate the system unless people really do put down the actual diagnosis. Finally, this is before the province of Manitoba adopted the opioid prescription intervention. They're going to do this now based on these data on other quality indicators that they were using from care management technologies. This is, again, one of the largest prospectively designed randomized trials ever done of this kind of audit and feedback system in which doctors' prescriptions are audited and then they're given directly feedback on what to do. Very important also to remind you that the clinicians in this system are totally on their own, totally voluntary what they actually do with this information. They can throw it out, they can act on it, they can do whatever they want. There is no, in this particular system, for example, in Manitoba, there is no governmental oversight forcing them to do anything. And all the physicians in the province of Manitoba were randomized to either receive the intervention or not receive the intervention. And again, although this is not opioids, you can see that the intervention significantly reduced the prescription of benzodiazepines, and particularly to older adults. And these are not just any benzodiazepine, but benzodiazepines where the doses were too high or the length of time was prolonged, and also hypnotics that are considered by most guidelines to be inappropriate for elderly people. So these audit and feedback systems do work to reduce potentially problematic prescribing. And so we hope that this is an example of the kind of thing that can be done using massive amounts of data and directing the information directly to clinicians, where you can actually explain to them not just that there may be a problem, but also what the potential solutions are. Thank you very much.
Thank you very much. There's some questions out there for Mr. Gorman? No questions, Mr. Gorman, I'm here. Oh, I apologize, Rose. Wait, you'll get a microphone. And then we'll go to the phone after Rose.
Just two quick questions on your comments regarding the provider putting the actual diagnosis down on the form. Again, with intractable pain, there is no ICD code for that, which puts us in this catch-22 again. I think this whole issue is a catch-22. Then going to these Canadian guidelines, I find that kind of interesting because my experience with Canadian guidelines on a different subject as well was there was a prescription for a blood pressure monitor for a cardiac patient who was supposed to have monitoring per the AME, and he'd had a heart attack. They denied it based on a Canadian guideline for diabetics, saying only diabetics should have monitoring by blood pressure monitors. And they didn't even consider the California Department of Managed Healthcare's guideline that said cardiac monitoring of blood pressure is a good thing. So it seems that there, while these Canadian programs are certainly something to be looked at. It seems that no matter where you go, there's always, we're chasing mercury, you know. And, but anyway, it just goes.
No, I appreciate those comments. That is absolutely a issue, the lack of a ICD-10 or any other intractable pain designation. This is just an informal study that I did, but trust me, I used a very liberal threshold. So if somebody had a sprained wrist 6 months ago and was still on an opioid, that was the kind of thing that was more common than seeing somebody with a diagnosis where you could at least say that's probably something that causes pain. And there were also instances that where opioids are really contraindicated, like migraine headache, for example. When my daughter did her, as a neurology residency, did her rotation through the headache clinic at New York Hospital, she told me that most of the work they did was taking migraine headache patients off of opioids whose headaches would then get better. And yet you see tons of people with the diagnosis of migraine headache on opioids, even though it's in every guideline. With respect to the Canadian guidelines, that's one of the things that we do. We actually help the province of Manitoba look at California guidelines, professional guidelines for other societies. So because we are responsible for looking at all the guidelines, we hope that the people who use our system will then actually pay attention to those things as well, and to comments like you make, because we're paying very careful attention to that as well.
Thank you. Any comments on the phone?
Any comments
We
from
have
the
no
phone?
comments.
Thank you.
Okay.
Hi, Scott Clark, California Medical Association. Thank you for the presentation. A question I have for you. I know Missouri doesn't have a prescription drug monitoring program. I think it's the only state right now that doesn't. And so some of the examples you used were from that. How would this work in a state like California with Cures? Is it limited to the information within the plan or provider group, or is it pulling in information from outside of that closed item? And I understand there could be benefits within that system, but would it address like the person going to a different system?
Again, it's so flexible that it can include information from any source that the client, so to speak, wanted us to use and could get their hands on. So it could be anything. I think it really complements things like Cures, because one of the issues we've seen in New York is that doctors have to look at iStop. First of all, even though it's mandated, my wife is a doctor. She looks every night. So I know she's complying. But we hear anecdotally that lots of doctors do not, even though it's the law says you have to. So that's the first problem. And the second problem is there's some user fatigue with it, because the vast majority of times that they check, there isn't a problem. And so this complements it, because we think the doctor should always check Cures or iStop or those. Plus, this directs their attention to the problem and also some solutions to it. So I think it works both ways, particularly in a situation where it's not mandated, or where, unfortunately, you may get a lack of compliance from the clinicians, which is hard to, we're not recommending that, but it's hard to control.
Okay, thank you. I think we're going to move on the agenda now. Thank you very much for your presentation. Oh, we have one more question. Wait, stop. I have one more question.
I stop.
But a question about the presentation, okay? Thank you. No, thank you very much. I promise we'll take questions and answers on general stuff. Not yet. Next speaker, Dr. Brian Solo from Optimum RX. Would you come forward, please?
Good morning. I'm Brian Solo, a physician with Optimum RX. Thank you, Dr. Bishop, Mr. Yaroslavsky, for having me, I think. So I represent a pharmacy benefit manager. For those who have not heard of Optimum RX, we currently provide services throughout the United States for over 30 million individuals. For those of you who read the news, we're soon going to make that 60 million individuals, as we've acquired another organization and looking to merge the two. So we had last year over 500 million prescriptions that were processed. So we are the company that handles the drug claim payment. So most individuals, and I suspect most of you in this room, don't know that you actually have drug insurance. You know you have health insurance, and it's usually bundled with health insurance. Sometimes it may be purchased separately. Sometime for the seniors here or out there, they may purchase a Part D, as in dog plan, from the government, which covers their plan. We don't set the benefits. That's up to the clients, who are third parties. They may be insurance companies, they may be employer groups, but we administer that benefit. And one of the things that we do, and Ms. Yaroslavsky asked me to come speak about, is what do we do in the narcotic utilization space. So I wanted to take an opportunity to describe our programs and give you an example of what we do for our non-senior population. Actually, it will include some of those, but then what CMS, the government, mandates for our senior population. And so I just wanted to walk you through, and it's similar to your last presentation a little bit, and I think you'll see some overlap. But again, this is something that is already in place. It's not something that anybody has to sign up for or get, but it's through your pharmacy benefit company. There are two other large companies in the United States, Express Scripts, CVS Caremark, who have similar type programs, so not unique. Everyone's a little bit different. So keep in mind that these are all based off of pharmacy claims. And one of the questions I had as I was preparing for this is, well, what do you do about all the individuals? And our first speaker may say, well, if I don't have a prescription, you won't see the claim, which is true. So this is just, again, about an educational piece that is part of Cures, part of every other little piece to fit into that milieu, because every little piece, I think, can count. So let me review our current program. We call it the Retrospective Drug Utilization Review. And the objective of that is to be a provider-targeted program designed to minimize the occurrence of drug abuse, diversion, and inappropriate use in members utilizing high-risk medications. So we actually look at a 3-month timeline for an identification period. We do an intervention monthly to prescribers, and then we also look for a diagnosis of cancer in the previous 6 months, because that is the one excluded category. We do not enter patients into that program. Currently, and this program is constantly updated, we look at guidelines from California, we look at guidelines from every state in the country, we look at national guidelines, we look at pain management guidelines to try to help look at these criteria. Right now, we have the following criteria in place. To give you an example, we look at those receiving greater than 4 or equal providers for a combination of opioids, benzodiazepine, muscle relaxants, opioid analgesics, benzodiazepines, muscle relaxants, chronic early refills of those oxycodone-containing products. Again, we get the claims. Many of you would say, well, if you're a narcotic abuser, you're probably not going to use your insurance company. You'd be surprised. They use their insurance company because these drugs can be expensive. We look at an overlap of greater than or equal to 2 extended release or long-acting opioid analgesics. We look at high daily doses of opioids, large quantity, and recently we've added over 4 grams of APAP, which is known as acetaminophen Tylenol. And as I mentioned, we do exclude certain categories. One of those, for example, would be cancer patients. We do not target the individual patient, but instead, as you saw in the last program, we do target the provider. We do mailings right now. Emails are somewhat hard. Most physicians don't want to give out their emails. All right. Faxes, they get about 50,000 faxes a day. Most of those are ignored. So we felt that mailings right now, unfortunately, and soon it will be incorporated into electronic medical records, may be one of the best ways. And those give the clinical issue of concern. They give the actual patient's name and the history. This goes to all the providers here. And what we found, and I was before, I've practiced for 25 years family medicine before I came over to this side of the business almost a decade. And what we find is that providers love this material because they may combine it with cures, but they also now, looking in front of them, they're able to see that I prescribe 60 oxycodone and then the following day they were in the emergency room in Los Angeles with our ER doc in the back who didn't have any history of what I prescribed. They got another 60 oxycodone. And then the following day they were at the physician's office down the street and got another 60 oxycodone. And they're actually able to see that and realize, one, there may be a problem, or perhaps there's not a problem. We don't take action and we let the physician carry that action. Again, like our prior presentation, this is information that is quite powerful. Powerful enough that we monitor the success of this. Last year we had a 54% success rate in looking post down the line, several months down the line, to see if those medications may be stopped. And we can track costs as well. Over $54 million in those drug spend were saved. This went out to about 275,000 individual prescribers with about the same number of patients. So again, a very powerful program, one that physicians, as opposed to many of the other things that the doctors in this room or on the phone may receive from pharmacy benefit managers, which they're not happy about. We don't restrict, except in the sense that we are the ones who may provide guidelines for proper use of medications such as transdermal patches for fentanyl, to make sure they're getting to the right patient at the right time, at the right dose. So that's an example for our one of our populations, and I just briefly wanted to touch on the CMS for those who don't know this, but CMS back in 2012 required companies like ours who are Part D managers and plans, and this is looking at the most egregious patients. These would be senior patients primarily, and they're looking for 4 different pharmacies and utilize at least 4 different prescribers for that combination and exceed a morphine equivalent dose of 120 milligrams. This program is a little bit different, though, is that they then are recommending companies like ours help these providers and the patients get into programs if it's needed. Again, we don't have the medical information to know, so we always leave it up to the prescriber. But this is one program where the government, CMS, says that if they are believed by their physician to be possibly abusing and there is no clinical diagnosis, whether it's chronic pain, anything else, that the payment for those drugs may be cut off. And again, that's a physician step that happens. We don't cut people off. We get that from the physician. We use proper management. But that's a CMS mandated program, just so you know. So we have obviously patients in California and every other state in the nation, but I wanted to give you some background on those 2 major programs, what companies like ours do. So again, a couple of points, and then we'll open it up for questions, is these are by claims. We don't pick up the cash patients, just like we have programs to keep people on statins after they have a heart attack. If they're buying their generic Lipitor, we're not going to pick that up. But these are by claims only. We take our guidelines and benefit. We don't set the copays. That comes from clients. So those of you who want to complain about copays being too high, wrong spot. And then our issue that we could use help with, and more of a rhetorical thing, is how do we get physicians to pay attention to these? Because I know personally my friends see an envelope with my company's name on it, and it goes right in the garbage. They won't even open it. So how do we get them to pay attention to it? Because they don't know what's inside. We don't put the patient's name and say, this is a narcotic abuser. We don't even know that. So how do we get doctors, just like the Cures, to help that? And I do think there's a great time with that. So with that, Barbara and Dr. Bishop, I will open it up if you'd like, or questions.
Some questions? No? Questions? Questions on the phone? Oh, wait, I have a question
We have
back.
no questions.
Wait, no questions on the phone, correct?
Yes, no questions.
Perfect, okay.
Thank you.
So we have a question back.
But to your question on how do we get doctors to pay attention, are there currently any consequences for a physician prescribing to somebody who, had they used the system, would have caught this person? Are there any consequences for a doctor who blatantly disregards, says, I'm not going to use cures, and cures could have saved the person's life? Or are there any consequences in place? And if not, perhaps that's a beginning to answer your question on how do you get doctors to pay attention, because I imagine they would pay attention were there an actual consequence for them not paying attention.
So what, oh.
No, I was going to say there's a cures answer, and then, of course,
Yeah.
we're not tied to the cures program, all right? Do we have consequences for doctors? We have a fraud, waste, and abuse system in place, and we're able to catch physicians, refer them to the appropriate medical boards if we feel that there's an investigative need.
So what we would do is we'd investigate that individual, and then through the process of having experts weigh in on the case, they would be looking at what was the standard of care. And in most situations, the standard of care would be to, obviously do an appropriate history and physical on the patient, check a lot of things, including looking at the care system to see if this individual was basically an individual who was a drug-seeking patient. So all of that kind of weighs into the fact that overall what we're looking at, what is the standard of care for that individual, for that patient, and what should a physician be doing. And so then what would happen is then we would file an accusation against the individual if they found that it was a departure from that standard of care, and then take appropriate disciplinary action, which could be anywhere from a public letter of reprimand to probation, suspension, revocation of that physician's license. So there are outcomes of that, yes.
Well, my question is, I understand the whole process, but is there any automatic triggering of an investigation based on cures data, and does someone mine that data to look for a potential violation of the standard of care?
So about a year ago now, we actually, because this whole issue that came before us with the epidemic that was going on, we actually turned one of our positions into a proactive position that looks at the cures and now is mining the data and is looking at it. So that was about a year ago that we've started that. Then what would happen is once we're looking at that information, we would be sending those cases out to our field for investigation and then furtherance that way. So it was about a year ago. Prior to that, we were getting information, and what we were really using cures for is to see was a physician prescribing to himself. We were looking at that, but now we've gone, or herself, absolutely. But now we've gone beyond that to where we're actually looking at it more. And I'm looking at Ramona in the back because that analyst actually works for her. So
We do the same thing. We mine data as well, and we'll turn that over. We can look at physicians individually, and we see the multiple number of patients. Interestingly enough, all 30 of their patients all live at the same house. So a little tip-off, and we have all that information, but it's interesting what they don't know we have. So it's there. But the other thing we have to be careful of is there may be a doctor prescribing a lot of pain medication. We then find out they're a pain specialist. They're an anesthesiologist. They run one of the largest clinics around, and they have many physicians under them, and they're on call. The ER docs don't like our program because they're just stuck in the middle. They've only prescribed it once, and we don't chastise. This is for information, which again, the physicians, out of the one thing doctors don't like is a sneaky patient who's trying to get pain medication, perhaps, who doesn't deserve pain medication. And you're right. All my patients lie who are sneaky, perhaps, and you guys are good at it, right? There's no doubt about it, and we can't tell. I've seen fake x-rays, fake records. There's just no way to do that. So again, it's just one more piece in the milieu. There was one other question?
But so what I heard you say directly, though, is that you do have this information and you do report to the medical board.
We will turn over if we have
information.
Yeah, absolutely.
So, and I assume other companies do the same.
Absolutely.
Okay. I see another question.
Hi, me again, Scott Clark, California Medical Association. And I thought maybe it's a moment to remind ourselves that the cure system has significant limitations. I get regular calls from physicians who get locked out and cannot get help from the Department of Justice to get back into the system. So, and I have also doctors who report that information missing, stuff that they prescribed prior than a week out. Some of the other examples we've heard, of things that the system is not there yet.
The system's not perfect?
Yes, that is correct. And I just thought it was
Oh,
important to remind ourselves
gee.
of that as we talk about what we're doing with that data and what we're asking people requirements, and we need to be mindful about where that system is right now. Thank you.
In the back?
Just one quick comment. So just to understand your question, you said, how do you get doctors to pay attention to the information? You have mines and mines of data, correct?
Correct.
And you're like, you mail them something. What's the time difference on the mailing that you send about a particular patient?
So again, we do monthly mailings, and we have to
That's
go.
your problem right there. Because to be useful for me to pay attention to the information you're offering me, it has to be real time. It has to be something that's actionable in the time that I'm making
Right, but we have to go back, and we want to make sure
Yeah.
it's not the matter of the real time. We have programs in real time, drug-drug interactions, that's real time.
Yeah.
Okay? But this, we actually will go back, mine the data, so that you know that in the last 3 months we can collect that. Because the last thing you want as a doctor is, wait a minute, I just prescribed this, the patient just broke his leg last week. I won't know that, so we want to go back, look at that, look at a 6-month cancer diagnosis as well. So sure, monthly, you might say, well, it's old data, but narcotic information, very interesting. These are the ones that, as best as we can, to try to give you the patient that may have a potential problem.
Right. If I'm the primary physician, I'll know when the patient comes back to me and how many prescriptions I've written them on the last time. But if you're talking about your true doctor shoppers, I'm going to see them one time, I'm going to write them for their 60 Percocets, and they're out the door, and they hit the doctor down the street. So even if you send me that report, I may never see that patient again, and that's where you lose the usefulness of your data.
So we'll list all the doctors who prescribed all that.
Yeah.
We'll see all the doctors in the
But I'm
neighborhood.
saying there's nothing actionable for me to do in terms of preventative
There
measures.
may not be.
out. Does that
We
make sense?
recognize it.
So let me ask you the question, the ER doctor in the back, that when you have a patient that comes into the ER, who mandates the number of pills that you give a patient? Is it done by the insurance company? Is it done by the standard of care? Is it done by the hospital? Is it done by the drug company?
So LA County DHS put out guidelines, and our group also has guidelines in terms of the number of pills that are recommended, right? These are all guidelines, nothing's mandated, there's no hard, fast rules. So the question is, what's reasonable for the diagnosis that you're sending them out on? So usually the general recommendation is no more than 3 days, right? Lowest
Thank you.
dose, no more than 3 days, and they need to seek primary care physician or a pain management specialist for that. So I don't have to, no one's writing 60 a Percocet if they are from the ED anyway, not anymore. And
You'd
so
be
we
surprised.
yeah, so that's why Cures is helpful for us, because we can actually count the number of tabs, even with the 1 to 2 week lag, doesn't matter. So that can definitely change the number, if I was like, oh, maybe 15, and then I just saw you had a script last week, now you're going down to 4. So that's the real-time actionable decision-making that's helpful, especially if you're like a one-time hit and you're talking about true doctor shopping. They're only hitting one doc each time, and those are the smart ones. So you can send me a whole list of 20 physicians in my neighborhood. It's not going to change what I already did a month
Yes,
ago.
the cures, for the ER, the cures is more prudent for you. This is really targeting the other family physician, pain clinic physician. And really for us, it's not the ER physician that we're trying to target.
Rose?
Yes. When you're doing your analysis of the patterns of prescribing, do you go back far enough to see if there's changes like trialing sustained release opiates, and then maybe those being denied and then having to resort to less effective medications, more problematic but less expensive medications? This is something I have seen.
Sure. Well, we're not case management, so we don't have the full patient picture. We do go back 3 months, but again, we're looking for specific criteria to try to capture out of our 30 million, the best we can, but point taken.
That may be one of the areas that's causing the problem. The other question I have is, you say you exclude any case with a cancer diagnosis in it. What about other health conditions where, say, a bleeding disorder, where taking aspirin can be very problematic and they might need Percocet?
Well, again, we look for the biggest basket we can capture, and then as the letter that goes to the physician, those of in the room who've received a letter from me, it will say in the first sentence that you, as the practicing physician or prescriber, have the best information about that patient and can make the best medical judgment.
Okay, thank you very much, Dr.
Thank you.
Solo.
Thank you. Okay, the next speaker we have registered to speak is Maggie Buckley from the pain community. Thank you.
Thank you for letting me speak. So many of you have heard me ask questions and comment earlier today. My name is Maggie Buckley. I'm with an organization called the Pain Community. The website's paincommunity.org. And I'm here on behalf of people with chronic pain, people with ongoing pain conditions that need care. And I am a person who lives with a chronic pain condition called Ehlers-Danlos syndrome. I was diagnosed at 13. So as I said earlier, since 1974, I've been a pain patient and have had opioids at many times during that program. I'm one of the lucky ones in that I was diagnosed in California at a time when things like visualization and biofeedback and new physical therapy research was being done for an unknown connective tissue disorder, which is not the norm in what you hear. So my experience in dealing with other people with chronic pain conditions and coaching them on what to ask for or how to get the best pain care management and helping them overcome obstacles with doctors or providers or teaching them how to ask for things has led me to understand that this issue of opioid abuse, diversion, misuse, etc., is really a very large problem. And every time we poke at one small part of it, whether it's the regulations or the laws or prescribing or patient education or whatever it might be, we only move a little bit forward, and maybe not even forward. We move a little bit sideways and forward, and then we create a bigger problem elsewhere. And I think that's what we're seeing once again as we put more restriction on opioids. There's the diversion that people are now talking about of, or the conversion of people now talking about going to street drugs or heroin or methadone or something else that they're getting illegally. Whereas the conversation needs to change as to what is the system that needs to be in place. And my experience with myself and with others is that it needs to be a multimodality approach. Unfortunately, our healthcare system doesn't support that because insurance typically pays for all the prescriptions you want and a limited number of physical therapy and a limited number of interventional treatments. But as Samir said earlier, it's a constant battle trying to get coverage for the complementary and alternative options or CBT or acupuncture or even nutrition counseling, which is a big issue for people with pain. So if we continue to move forward together, and we all know that the objective is to get the best pain medication or the pain management model in place, then I think the opioid and abuse issues can be headed off earlier on in the process. The example that was given by our first speaker today is ideal for comparison of his experience and my experience. I was fortunate enough, even though my family has a history of abuse throughout the extended family, I was given early on, as a teenager also, a variety of treatments and an understanding and a training and a lot of people involved in taking me in different directions to manage that pain in one thing. Whereas his only option was prescriptions. That's all he was given. That's all, and he was taught and trained by the medical system how to get more prescriptions. So let's all bear that in mind. That's what I wanted to my big message. And then I want to highlight the fact that this has been one of the few processes. As I said, I've been doing this for 25 years. 25 years ago, I finally had enough and stood up and started talking to doctors and advocacy boards and medical boards and legislators, et cetera. And it's only been in the last couple of years that I've really felt truly involved in the process, and it has been these people over here to my right that have given me that, which has helped tremendously. If we're heard, if we're involved in the solution, then I think we're all going to be happy. So let's continue to include all the stakeholders in the process. Thank you.
Does anyone have any questions? Okay, thank you very much. Any questions on the phone?
We have no questions on the phone.
Before calling our next speaker, I think relevant to the whole discussion today is that this meeting today has been sponsored by the medical board, and we have a limited purview over what we control, I guess is the proper word. And we certainly welcome input from all stakeholders. However, this meeting is not an appropriate venue for a specific complaint, except in a small example. That we do want stakeholders to express their concerns, but again, we have a limited purview of what we represent, and so just going forward, I'd next like to call Rose Turner from the public.
Thank you for having me here, and I've provided written things that...
Use your microphone, please.
Sorry. I provided written materials offline, and there's more information for that.
And those will be dispersed.
Right.
So.
Yes, I understand. I have a big stack for just 2 months' worth of time, and this is sort of the essence of it, of appropriately legally prescribed medications that are being denied. And in order to ensure the health, safety, and welfare of that patient, I have had to put out, and I'm not related to this person, I have had to put out over $500 after all the co-pays are paid for things that 2 years ago were automatically paid for because medical necessity had been established. All the changes in the programs are impacting the patients, and it's causing great harm. This isn't the patient that had the heart attack when his medicines were abruptly stopped by a person who wasn't even involved in the case. There are people doing utilization review where the companies are owned and operated by chiropractors. And they are writing the reports. They get somebody to sign it electronically. They edit the report after it's signed, and it doesn't follow the different guidelines. And that's beyond their scope of practice. Evidence-based medicine, it's a great thing. It's a wonderful thing, but it's not the be-all and end-all. There are times when the actual case history is the best evidence-based medicine. What actually happened when this happened or that happened. There are times when it's unethical to have a study because you just cannot do that. So it should be used to rebut, but not to deny care, and certainly not without due process. So I think making sure that the laws that we have, in fact, on the records to establish medical necessity, those need to be prominently placed so that we know that there are people who are entitled to and need that. They will never get better. They will never return to work. They will never be cured. And they're the ones that need the most help and assistance. It's a catch-22 because everywhere you turn, there's somebody making rules without following the rules that are already in place, making assumptions, not presumptions, when presumptions prevail. It just gets to be very, very, very difficult when you have to help somebody. I have been a 24/7 caretaker for a severely disabled person who, in addition to the spinal disability, that's a total disability, apparently during the surgery he had for that, he had brain damage. So he's got memory in the 2nd to 5th percentile. He will never be able, even if we took away his pain totally, he would never be able to go back to work as a paralegal. He just could not. And yet, every month, we have to go through this. I have had to put out thousands, not just in the last couple of months, but thousands of dollars of my own money that someday I might be reimbursed for, to make sure that he remains healthy. He's getting absolutely appropriate care. And there's just too many people who are intervening in the receipt of appropriate medical care because some people abuse medications.
So, Rose, let me ask you the question. What can you impart to this body and to us specifically on some specific practices that maybe should be reevaluated, relooked at, rediscussed, rethought?
Well,
versus the bigger picture.
Yeah. The guidelines that are available are confusing. There's different sets of guidelines from the same organizations. And depending upon which organization you're having to deal with, which entity you're having to deal with, there's different criteria.
Okay, so let's, point by point, from the medical board's perspective, are there specific guidelines that you could help us with to point out so that we could take a look at possible clarification?
Okay. In your latest, I didn't print it all out, just the part of it, the preamble where it says in the 4th paragraph down after the one.
Just tell me what it says. We're pretty familiar with it.
Some of the recommendations cited in these guidelines might be appropriate for other types of pain. They are not meant for the treatment of patients in hospice or palliative care settings and are not in any way intended to limit treatment where improved function is not anticipated and pain relief is a primary goal.
And you would like that to be more structured or more? We tried to leave that as open as possible.
I know. And
you don't find leaving it open is a good idea?
Yes and no. Leaving it open, the liberal construction is paramount in administrative law.
No, but is this impeding your ability to do what you do?
Yes, because the law, the Business and Professions Code and the health and safety codes that allow for the specific treatment of intractable pain, where improvement is not there, has disappeared. Therefore, the people who rely on regulations and the word from regulators, they say, well, it's not there anymore, so it must be gone. They don't say it's not there, therefore we can do it, which is what they're supposed to do. And that was in the old policy. That was where it started. Then if you take that and you take it into the different populations, it lessens the strength that was there before.
So let me ask you a question. Could you provide the medical board with your comments in writing so that we could look at it?
Oh, yes, yes.
So that would be very helpful.
And I can give you examples and cases where decisions have been made where the wrong guidelines were followed, and that's why there's a lot of documentation.
Let me suggest that you give us that in writing, and then you could get some written response from our executive director. I think that would be very helpful.
Okay.
Again, I also want to emphasize, keep in mind that the medical board does not regulate the insurance industry, nor do we regulate workers' compensation, nor do we regulate anything except physicians. So we're happy to work with you on this, but unless there's some malfeasance of a specifically California licensed physician, I'm looking at my legal representatives, we really have no legal say in any matter that's outside that purview. But we certainly welcome your comments, and I know that Ms. Kirchmeier can help you to direct your comments in a way that in writing that can be helpful in hopefully solving your situation.
Well, one of the problems with that is in making complaints regarding the misappropriate practice of medicine, and they have been referred to groups that don't have jurisdiction for it, and when you try to place it with the medical board, it gets sent back. So it gets sent around a circle where when it happens, you can't get the complaint through.
And I know that we've had people complain to us. I think the last meeting, one of our prior members complained about this specific situation, And again, that's kind of a sticky situation, but we understand that that occurs. We've had this medical comp reviewers not being qualified, and so I think that's a valid concern, and I think we want to address that. It is sticky. It's going to be difficult to work on that, but I think it's something to look into, so we welcome your comments.
Out-of-state physicians altering prescriptions.
Absolutely.
That happens every day.
Okay, so you're going to make sure you get something in writing to our executive director. Okay, thank you very much. So we're going to move, I've asked for phone comments, there were no phone comment questions, and there's no more questions in the audience. So we're going to move on to next.
Next speaker is Jamie Eng.
Give a microphone.
Or you may come up if you'd like.
No, I'm okay sitting here. So we were talking about best practices, and I was just interested to hear if anybody else is moving this direction. So Washington State and Washington Cal ASAP. Again, this tends to be a little ER geared, so sorry.
It's your world. We welcome hearing about it.
So they instituted something called EDI. It's EDIE, the ED Information Exchange, and they've connected 68 ERs in all of Washington State. And so, okay. Hey. And what they've done is connected 68 EDs. I think they're just missing like 11 in eastern Washington, which is essentially Idaho. And what they're doing is collecting information from each of these EDs so that when patients show up in different EDs, there is a notification pushed to the provider in 2 to 3 minutes of registration. So this is real-time notification that's actionable with information. So if that physician wanted to get more information, they can then seek out, because this is the initial bolus of information that's useful to them. And then if they see chronic abdominal, and it lists the date of the visit, where they visited, and what their diagnosis was. So the diagnosis is chronic abdominal pain, chronic abdominal pain, chronic abdominal pain. It's all listed on this report. Well, the report also includes radiology alerts. So if someone with chronic headache or migraine and they've had 9 head CTs in the last 2 months, it will also show up on this report. If they have an outpatient care plan established by either their primary care physician or pain management specialist, it is also included in the report. So when they show up in the pain management care plan says, do not give parenteral narcotics, and that is on the report, and it helps guide the ED physician in terms of their treatment. Ultimately, what it does is it provides consistent care within a community, even though the physicians may not know one another, through this single report. So we've actually instituted this in San Fernando Valley in the greater Los Angeles area. We have 10 hospitals, we're rolling out, and this is multiple hospital systems. Dignity, Providence, some Independence, Prime Healthcare. These are all, we have 10 hospitals wrapped up, Kaiser. And we're all connected, and we are now instituting multidisciplinary committees to create care plans, which actually addresses kind of what you brought up before. So you identify your drug seeker and you've booted them out the door, but you haven't done anything in terms of care for that patient. You haven't referred them to pain management. They're probably Medi-Cal. There's one inpatient drug rehab Medi-Cal bed in the entire county that's available, and that doesn't come up easily. So these patients are really not getting care. They're getting discharged, but they're not getting care. So we've created a multidisciplinary committee to address these patients specifically, to assist them in their care. Number one, to get them consistent care. Number two, to prevent multiple ED visits or unnecessary hospital admission, and get them the therapy or rehab that they need. A lot of them are Medi-Cal. They have a primary care physician. They just don't know that they've been assigned, and they don't have the resources on the outside to do it. And a lot of these people are homeless. They have mental health issues. So it's a package deal, but you're just discharging them and shuttling down the street. So that's something that we're piloting in LA right now, and we're modeling it after Washington State. And Cal ASAP has already put out like 7 best practices and basically creating consistent care committees, and in electronic information exchange is one of their best practices that they're recommending. So I wanted to know if there are any other areas in California that we're doing what we're doing, if we could wrap it up.
So I have a question before you find out if anyone else is doing this, is how did you get those different entities to talk to each other? We have a situation here in California in the state that the DOJ and the AG's office, they don't even talk, their computers are not compatible. They can't talk to each other. How did you get it so that those entities, which are not all of the ERs in the county?
They all have different EMRs, that's correct.
But how did you get them so that your computers can talk to each other?
I didn't do it. So
I
there's
figured you did.
so
Mitch
there's a software
huh?
company who actually, it's called CMT, and they're the ones that launched in Washington, and they're actually went live for the last year in all of Oregon. So they're slowly moving down the West Coast, and they've seen dramatic increases and improvements in their resource utilization, basically, especially in their serial inebriates, drug seekers, and then even it's moved to chronic medical problems like the asthmatic who will not get a nebulizer machine at home, so they just come to the ED for their breathing treatment. So things, it wraps up everything. How they do that is basically they look for, it's called I don't know how you really want to know. It's an HL7 feed. It's the most
I have
basic.
no clue what you're talking
it's
about.
the most, exactly, I don't know if you want to know. It's
No,
the
but I
most
wanted to
basic
know,
data feed
I was being
in any
facetious, but
EMR.
not facetious. We have a major problem here in California.
Yeah.
Where we can't talk to each other. We can't share records. A Cedars doctor that works in the hospital cannot share records with a Cedars doctor whose offices are not in the hospital. How, and that you can take these 7 or 10 hospitals that you mentioned or systems and got them to participate is amazing. I mean, it's I'm shocked.
So the data feed itself is just HL7. It's like the most basic streamlined data that gets transmitted. And we're talking, it's like a binary code. So it's, you take the most basic and the most necessary information and it gets loaded into a server offsite.
Can we do that
So
with Breeze?
we just work with the IT departments and had them all create the HL7 feed to the same server. And then we literally went ED to ED and pitched this to each of their ED directors.
It's fantastic.
Then we moved to the C-suite of the hospital because they have to, there's like a service agreement that has to happen. And so we pitched it to them as a physician group, and that's how we approached them. And so we got 10.
I'm really totally amazed.
So, Dr. Ng, can I ask who led this collaboration of the EDs? Do you know who?
It was.
group?
We actually came across it as part of our own. In our own group, we were trying to create narcotics guidelines, and this happened about the same time you had your first meeting last year.
All right.
So it was actually fortuitous. We were actually looking for best practices and how to move forward implementing it. So it's my ED group is Emergent Medical Associates, and we trialed it at Providence Tarzana, so Providence Health Systems, which is in Washington State and Oregon. Then we found out that they had already rolled this out in Washington for 5 years, and then Oregon last year as well. So we piloted at one of our EDs, and then we just kind of started taking over. Because in the San Fernando Valley, it's 2.3 million people alone, just in the San Fernando Valley, not even going over the hill on the 405 to the rest of LA. And so we had a lot of regional density, so that's why we decided to pilot it there in the valley.
The perspective in LA County is there are 10 million people approximately in LA County, which is bigger than 80, and then it's bigger than 42 states in the country. So when you talk about this program going and working, it's huge, huge. I mean, really fantastic.
So the money is really the care plans. It's creating the care plans with pain management, social services, mental health, and the primary care physician. So that's really where the money is if you really want to talk about like consistent care for patients rather than just shuttling them down door to door to door to door. So is anybody else doing? So we're looking.
Here's a hand.
Oh,
We
so
have a
we're
hand.
looking for percent utilization, like change in percent utilization, your top 20 offenders, number of radiology scans, number of patients per 1,000 that are insured, and specifically Medi-Cal. So we only went live. We started collecting data November 20th, so we're only 5-6 months in. But we have a lot of people, so we're just continually collecting data. We'll be able to generate an actual comparison report in like a year. So that's when we're actually going to know whether, because that was our baseline, November 20th was our baseline, and we're hoping 1 year later we can actually have a comparison study just in terms of utilization. So even if you just take the most basic thing, you don't talk to any other hospitals, and you just collect the data, and you're just like, I want to see the top 20 visitors to my ED, and you just focus all your social work and case management issues on them, right there you can decrease the amount of utilization and refer people to the appropriate care centers other than the ED, including narcotics. So.
Before we have excellent comments, and before we go on to the other speakers, I just wanted to say that I've talked with Ms. Kirchmeyer, our executive officer. We'd appreciate it if you would chat with her offline and consideration for putting something like this on our agenda for a full medical board, just for a pathway that we might consider for the state in other ways. So if you wouldn't mind speaking with Ms. Kirchmeyer offline afterwards, we'd appreciate your input. Okay. So move on to well, I know we're going to move on to comments on her presentation now. Is that correct? We're comments, questions about her.
Yeah, I was just going to sort of echo that. My name is Kevin Jones. I'm an emergency physician here in Sacramento. And we've been working here in Sacramento to try to do exactly that. So I sort of echo her comments. And they're sort of farther along in the process than we are. Here we have sort of 4 major groups: Dignity, Sutter, UC Davis, and Kaiser. So we've been working, Dignity has been on board, and so we've been sort of in the process of trying to get the other hospitals, and that's sort of been the sort of challenge, and to be able to get the funding for these hospitals to chip in to be able to do that. And so I would like to, certainly support that. I think that's going to be sort of the challenge to get specific counties and then within that their hospital groups on board. But this is something that I think would be very beneficial and would address what we're talking about today.
There's another comment over here, but before you do, I think the issue is that we don't always have to reinvent the wheel. The wheel sounds to me like it's been invented, so that maybe you also should be speaking to each other.
Hi there, I'm Jeff Hogue with the California Society of Anesthesiologists, and I'm also medical director for pediatric surgical services with John Muir Health in Contra Costa County. One thing we've noted is what a lot of people have alluded to today is appropriate follow-up. In your case, Jason, do you think it would have been helpful in that first month after you were discharged from the hospital if you had had more hands-on follow-up? I think that that's something that we're trying to look at our system. We're a trauma center also. And I had a trauma patient, 21 years old recently, and just the other day we spent, or myself, 2.5 hours on the phone just trying to line up appropriate outpatient services. And you magnify that by a couple of dozen of trauma patients per week, it adds up. But one of the things we've instituted is an extensivist program at John Muir Health where we target complex patients being discharged from the hospital, and often their own primary cares are very busy, their offices are full, their margins are very tight, and so we have these patients come on a weekly basis that first 30 days to be seen by a hospitalist who has what we call an extensivist, and that has been vital, we think, to promoting good follow-up and getting them on maybe the correct pathway going down the road and helping with additional follow-up. The problem, of course, is with adequate reimbursement. Insurance companies, CMS, Medicaid often will not pay for these services. Right now, these are things we just do because we think it's the right thing to do. An analogy to that, I think Dr. Bishop is familiar with this, preoperative clinics, which in our specialty, anesthesiology, are critical. We have a very large preoperative clinic program with John Muir Health. There is no reimbursement to the hospital for that, but where we make our money is on the downside by fewer cancellations in the operating room, fewer complications, and better care. And the complication issue is an important one because as we head from fee-for-service to more value-based payments going down the road, and then penalties for readmission for things like infection, what have you, in the immediate post-operative period, having a system in place to prevent these types of things are critical. So what I see in the healthcare system, at least on the inpatient side, is good, down the road follow-up begins with preoperative evaluation if it's elective surgery, or good case management in the OR for a complex trauma patient that will require complex follow-up, and then this extensivist program and immediate post-op intervention within the first month to keep that patient on the right track. And we're going to be following our data and our metrics to see how that goes. But I know, Dr. Bishop, you're involved with that as well. Would you echo?
Right. And what I keep hearing is a theme here. And, the state of California, thanks to Governor Brown and the legislature, is starting to come out of one of the worst fiscal deficits we've ever had. And so it's always about the money now. Of course, we all want our patients to do well, but it's all about the money. So it seems to me that what we're all saying is the same thing, that the challenge is how do we convince and prove to our state and the people that hold the purses that these preventive programs, that these programs that look at complications, identify patients early on, is going to be cost effective. And indeed, it will, because if you can limit these ER visits, decrease the glut in the ERs, all these things treat our patients with addiction potential, maybe early on before it's ironclad. So I think what we're hearing today, what at least I'm hearing, is somehow get this group or whatever group we want to go to, but somehow get this to be a package deal, convince those people in power that this whole picture of trying to address the patients in a more multifactorial way to prevent unnecessary and harmful medical care and not give medical care that's necessary too. So I think that should be our focus as we come together here at this introductory meeting, and how can we convince these powers that this is the way to go now, that more legislation, more strictures are not the answer, but more organization and working together. And I think as we're finding, as government becomes unwieldy, the grassroots efforts that we're seeing and hearing about today are remarkable. And that's where I think the future, this is my editorial, that's where it lies. But I agree with you 100%.
Dr. Ingers, have you been in communication with San Diego County? Because I know their ERs have really taken ASAP. You guys have really been involved in the San Diego area, where I heard of a lot of the ERs really working together. They developed guidelines that were then adopted, I believe, by all of the county down there, and I think it's moved to other counties. The Sacramento's looking at it as well. Now I'm taking it then.
Prescribing guidelines as well within the last year.
Okay.
In conjunction with San Diego.
Yeah, so I think a lot of them are working on that as well. So if you might want to contact ASAP, because I know that they have really done a lot, and I know that came from Dr. Sugarman, I think really out of San Diego County first.
Yeah, it was Dr. Lev who headed that up down in San Diego, and we actually did a joint press conference with the DHS Narcotics Task Force. So LA County's DHS has a separate task force specifically for misuse and abuse in LA County. Dr. Lev came up because we used a lot of the templates from San Diego for LA County. So we've been in contact with her. In terms of EDI, they don't have EDI. What they have is Cal Optima, and that basically is Medi-Cal patients only, and that's how they're tracking it, but it's not shared. It's not a push function. It's just a general HIE. So you open the record, you get everything, not necessarily the pertinent information to actually make an active decision in real time. But we have been talking to them, so we're trying to move forward using LA's DHS as like a springboard. Yeah.
Okay. Great.
Okay, I see Jason has a microphone in his hand. Did you want to speak about shared responsibility again?
One of the big differences between Washington and California, I know from having done a series on cures, is the state of Washington running it through their Department of Health, as opposed to California partnering with the Department of Justice. And the Department of Justice is so cumbersome, and which is making cures so cumbersome to the point that we're actually having other we're having other systems pop up doing the job that cures has set out to do, and now we're doing it on a grassroots level, which makes me wonder, why are we still funding cures? And so having said that, and one of the other big differences between California and Washington is Washington will alert its physicians when if they are operating outside of their scope of practice. So for example, the PDMP that the state of Washington has set up, all the doctors, they communicate. So if a doctor comes up and this doctor is prescribing, chances are the doctor doesn't realize what he's dealing with. And we're talking about cures, which is sort of, by its very nature, is a reactive system. It gets it when it's too late. But what about the doctors educating the actual physicians who might be overprescribing and not realizing they're overprescribing? And I can speak for that personally as someone who, I was prescribed 150 micrograms of fentanyl every 2 days.
I assume that's a lot, but I should tell
It
you
is,
that
but
we're trying to do education for
I
physicians.
think you mean milligrams.
Micrograms. 150
An hour.
micrograms
An
every
hour.
2 days,
Yeah.
the patch. And the point is, that's an ungodly amount, I found out when I detoxed. But it was prescribed by a family practitioner's physician's assistant, operating outside of a scope of practice. So when we go back to the state of Washington, they can catch these problems that California is dealing with 2-3 years too late.
And the
catch them at the
population in
time.
Washington versus the population in California?
Which is why I think the cures as a system for a state of California is failing as badly as it is.
And so I know, I don't want to speak out of turn from the Department of Justice because they haven't ruled out all of the improvements under the CARE system, but I do
Do
know
they have
that.
employees now?
Excuse me?
They have employees on cures now, the DOJ? More than one?
As of July, they should. They do have more now, though.
Full-time, yeah. I'm
Yeah,
sorry.
working on it. But I do know that some of the hopeful improvements of the CARES, they're calling it CARES 2.0, are those alerts that you're talking about. So they want to not only to be able to have a dashboard for those individuals, so when a physician logs in, if they were to log in and they were going to go see that patient, and have alerts for them, kind of showing the red flags on certain of their patients that they have put in as their patients. I know that that's going to work. I think maybe even pinging the individual to let them know that they may have an issue with this patient. So I know that that's where they want to go with the new care system. Maybe some of the things that Washington is doing.
Okay, I'm going to suggest that we really need to consider moving, one more, and then we need to move on to some more of the speakers, okay?
Yeah, Kelsey McQuaid, California ASAP. I'm their government affairs director. To the topic of LA County coordinating with counties, our safe prescribing guidelines were released last year. We have tools to communicate with patients specifically for emergency physicians. And we also have letters that emergency physicians can send to local family practice physicians in their county once their county has signed on to the program to try and communicate, this is what's happening in our local EDs. We're only going to prescribe, 3 days worth or less, depending on what's clinically indicated. And that way they can get the message across to the local doctors that, don't send your patients to the ED looking for a refill. We're going to be referring back to you. And we've had a number of counties sign on to this. Riverside, Orange County, San Diego spearheaded the effort, LA County. We've had Monterey and a number of others throughout the state. And we've had the Emergency Nurses Association, the California Hospital Association, and the Medical Association sign on as partners. So we're still in the process of rolling this out statewide for all of our EDs, but we're getting the ball rolling, and we're trying to work on that patient communication and coordination with other providers as well.
Okay, that's good. That's good. So, Dr. Stephen Henry.
Hi, I'm Stephen Henry. I'm an internist. I work at UC Davis here in Sacramento, and I just...
You need to stand up so the camera can see your face.
My name is Stephen Henry. I work at UC Davis as an internist. And I just had a comment in terms of educating physicians. I know that the medical board website has a section on the required CME already for the geriatrics and hospice end-of-life pain, and I just recommend possibly having a separate section or a separate outreach or something for a list of available CMEs specifically related to opioid prescribing, opioid abuse, and treatment of addiction. I know that there's a lot of programs out there. There's been a lot of funding, some of it from the pharmaceutical companies mandated by the FDA to create a lot of free CME programs. There's programs focused on primary care treatment of addiction with buprenorphine and things like that. So I think that might be a good resource, something fairly easy to put together for interested physicians and prescribers.
Okay, thank you. And questions on, any questions from the phone? No. Okay, and Scott?
No questions.
Yes, no? Yes, no questions. Scott Clark.
Hi there, Scott Clark, CMA. I'll be real brief, but I wanted to make sure people were aware of a national effort right now, which I think is going to be very helpful, probably more in the medium or long term. But the National Pain Strategy has just been released. This is a follow-up. This is basically part 2 of IOM's Relieving Pain in America. We identified the tremendous burden of pain in this country, and this is a strategy action-making document that's available right now for comment. It is it's about 40 pages, but it's very readable. They've done an excellent job of constructing an action plan that that covers a couple of areas. It includes needs in population research, prevention and care, disparities, service delivery and reimbursement, professional education and training, and public education and communication. And some of the underlying things they're doing in this are identifying the tremendous gaps in knowledge that we have about some of the best practices and setting out a research strategy to evaluate and identify what's going on out there, some of these things that we're hearing about included, as well as emphasize the need for education of certain groups and how those education efforts might look. So I think it'd be a very nice complement to what is going on here. It's open for comment right now.
So it's asking for comment. It's not a document.
It's a guideline.
It's not a finished document, correct?
It's a draft document right now.
So is your organization making an effort to publicize it with your members so that they should know to weigh in on it?
Yeah, well, we're also doing that, but I want to make sure everybody in the room is aware of that because I think it's a very exciting document. It's also very well balanced in terms of the various concerns we've heard. And some California representatives are involved, Dr. Fishman, Dr. Mackey, for example, who have been involved in some of this conversation. So if you Google search for that, I'm sure you can find it. But it's an interesting opportunity I think will help us get our hands around some of the evidence-based issues as well that we're dealing with right now.
What would I Google again? What specific
National Pain Strategy.
National Pain Strategy.
And
Thank you very much.
2 weeks ago. Thank you.
Okay, any questions on that comment? Any questions or statement from the phone?
We have no questions from the phones.
Any more statements from anyone in the audience? So I want to take a moment to thank you all for coming. For me, this has been a long time coming and a long time putting it together, and I can't thank staff and specifically Ms. Kirchmeier for making this all happen. She totally has changed the face, in my opinion, of what we're doing and trying to engage all of our stakeholders to try and show up to participate in a discussion. We can't fix everything. We can try and fix some of the things. And without your participation and without your engagement, we're talking to ourselves. I'm not a doctor. I'm not a professional in this perspective, but I am a consumer of medical treatment more than I'd like to have had, pain more than I'd like to have had. But it's also a situation where I feel that the public has been very well served at this medical board with the ability to put on these public meetings on regardless of what the subject is. And I want to thank you. Dr. Bishop?
Ditto. I think as I've been with the medical board now for a few years, I actually find these smaller meetings to be much more productive, at least for me personally. And I see a lot more gets done at these. I see networking, and business is very good at this, and medicine isn't. But this networking business is really fantastic, where we hear from the people in the trenches. We hear what other people are doing. And after the meeting, a lot more good stuff gets done. So we perhaps connected some people today because really we see how well our national Congress takes care of problems. And so I think, and this is going to be a little editorialization, but I think the more we take an active role and try to work again at the grassroots level, we get more done more effectively and more quickly than relying on the cumbersome process of state and federal legislation. So I think we want to be participants in that, but I think this is a sort of meeting where you're really going to get something done. And so I really welcome this, and I hope and again, kudos to Ms. Kirchmeier. She's been a breath of fresh air after a bad sleep, and I think that we hope to have more meetings like this in the future.
I want to also suggest, Jason, your speech in the beginning of this, your comments and your personal journey resonated with me a lot. I really strongly believe that eventually we will get to the point where we will have EMRs, that every doctor will be able to talk to every other doctor, every prescriber will talk to every prescriber, and hopefully there will be a point where there will be reimbursement enough for doctors to consider complementary medicine, to consider the benefits of not having to give a prescription but for medication, but rather for treatment and for improvement, because we all want to live in a situation where we feel good. We can walk up the stairs and down the stairs more than one step at a time. So I want to really thank you and thank all the presenters today. But I think that Dr. Bishop did touch on it, the need for all of us to be engaged with our elected officials, that they need to hear from you, they need to know your opinions, and they need to know your focus. No offense to all of those that are not watching, they're bean counters. So when that phone call comes, that letter goes, that email comes, they are paying attention to that. And that's the only way to change the system, is that those people that are in charge of making the rules and the laws hear from the people that it most affects. So I charge you with a free ability to pick up that phone and make those phone calls. It's really important. So on that note, I'm going to suggest that it's 10 minutes to 1. We're finished 10 minutes before time.
Excellent.
Thank you.
Give yourselves all a hand.
Kim, you did an amazing job. I'm telling you, amazing.